and let's talk about injuries to muscles, bones, and joints. So this information comes from the updated 2021 National EMS Education Standards, and so we're going to dig into the realm of trauma, and we're going to talk about open fractures, closed fractures, dislocations, amputations, and then specific trauma to the head, face, neck, and spine. And then we're going to cover the age-related assessment and treatment modifications for these diseases of concern. So as an EMR, you will encounter many different types of musculoskeletal injuries. And so some of the stuff that we're going to talk about tonight includes fractures, dislocations, sprains and strains. We're going to dig into head injuries, specific spinal cord injuries and management, and a little bit about chest injuries. So injuries to the chest wall and the breathing mechanism. And understanding the basic anatomy and functioning of the musculoskeletal system is going to help you treat these injuries. You have to be able to recognize signs and symptoms of a variety of musculoskeletal injuries, and then this will allow you to provide proper care at the scene and prevent additional injury or disability. And so, as we've been discussing this whole time, it all comes down to this systematic method of assessment that we've given you. When assessing a patient who has sustained an injury to the muscles or bones, you need to complete all 5 parts of this patient assessment sequence. A thorough scene size-up, especially if there's some sort of traumatic injury involved. Don't get tunnel vision because the patient has an obvious injury. It's very easy to see something torn open or poking through the skin and sort of focus on that. To the exclusion of important life-threatening injuries like airway, breathing, and circulation problems. So be especially careful about following standard precautions to protect you from patients, especially if they're bleeding. Perform a complete primary assessment to determine whether the patient has any life-threatening problems related to airway, breathing, or circulation. And it's often more efficient and helpful to perform your primary assessment and then immediately follow that with your secondary assessment and hold off on getting a patient's medical history, especially when trauma is concerned. Because generally speaking, once we complete the primary survey, the secondary head-to-toe assessment is where we're going to find any additional injuries, and history taking is going to take a secondary role to finding and treating all of these secondary injuries. And so again, understanding when to place the secondary assessment first or when to do history taking first. We'll talk about both of those things tonight as we get into the medical assessment as well. So for trauma, we tend to do the secondary assessment first because that's a more physical, hands-on approach to patient assessment. And in medical, we tend to do the history taking first because medical patients tend not to have traumatic injuries. So once we go through the thorough and systematic examination of all parts of the patient, we then want to do a thorough sample history to make sure the patient doesn't have any medical conditions that caused their traumatic injury. And then once we take a set of quantitative vital signs, we'll do our reassessment. And remember that we reassess the patient every 15 minutes for a stable patient and every 5 minutes for an unstable patient. So let's dig into some anatomy and physiology. Your skeletal system consists of 206 bones, and it's the supporting framework for the body. We wouldn't look like a human if we didn't have bones to give us a shape. And so the skeletal system has 5 major functions. The first is that the skeletal system provides structural support for the entire body. The individual bones and groups of bones provide a framework for the attachment of soft tissues and organs. This includes muscles. Bones are also a source of minerals. The minerals in bones serve as a valuable reserve that maintains normal concentrations of things like calcium and phosphate inside your body. Bones also store fat as an energy reserve in areas filled with what's called yellow bone marrow, and so you may be familiar with this if you cook with bone marrow. The fat is where the flavor is. Don't eat people. That's important. Um, and then bones are where blood is made. So red blood cells, white blood cells, and other blood elements are produced within the red bone marrow, which fills the internal cavities of a lot of different bones. Bones also protect us. The skeletal structures surround many soft tissues and organs. For example, the ribs protect the heart and lungs, the skull encloses the brain, and the vertebrae or bones of the spine shield the spinal cord. And then we're going to talk about the pelvis, and the pelvis cradles the delicate digestive and reproductive organs. And so a lot of these bones have a protective mechanism. And then finally, they serve as leverage. So many bones function as levers that change the size and direction of the forces generated by skeletal muscles. And so the resulting movement range from delicate motions of fingertips. We can, text on our phones and we can type on a keyboard, to powerful changes in the position of the entire body. So we can use the large muscles of our legs to lift and move patients, as an example. And so the skeleton as a whole is grouped into two divisions. First, we have the axial skeleton, and we hear about axial loading in C-spine, right, which we'll talk about a little bit later. The axial skeleton forms this up and down longitudinal axis of the body. So this includes the skull and the associated bones of the skull, because there's a lot of them. The cervical spine, or the neck, the spine, which is also known as the vertebral column, and then the rib cage. So everything here colored in yellow is your axial skeleton. And then attached to that is what's called the appendicular skeleton, right? This includes bones of the upper and lower limbs and those of the pectoral and pelvic girdles. So that's like your shoulder blade and the pelvis. And these all serve to attach the limbs to the trunk, or that axial skeleton. So it all comes together to make the skeletons that we see in the stores during Halloween. So let's go down through each one of these sets of bones. So we'll start with the head. So the bones of the head include the skull and the lower jawbone, right? And these are the two parts of your skull that moves. No other part of your skull should move if it's not the jaw and the skull. That's very bad if anything starts moving. The bones of the skull protect the brain and guard the entrances to the digestive and respiratory systems, which is your nose and mouth. The skull also houses special sense organs for smell, taste, hearing, balance, and sight. The skull is actually a lot of different bones fused together to form a hollow sphere. And then attached to that, you have the jawbone, which is a movable bone that completes the structure of the face. So up in the pocket over by the ear here, we have what's called the mandibular joint, or the temporomandibular joint. So if your jaw clicks when you chew and you've been told that you have TMJ, TMJ is actually the name of the joint where the jaw attaches to the skull, and that's what's popping. So a disadvantage of having this bone sort of attached at two places is that it's very easily dislocated with very little force. So if you get smacked in the face really hard, you can dislocate your jaw. And one of the tests that we can do if someone has like gotten into a car accident and the airbag's deployed or something like that, is we'll ask them to close their mouth and we'll ask them if their teeth line up like normal, because if their jaw is dislocated, their teeth aren't going to line up, and that's sort of an easy test that we can do to see if they've dislocated something. So that's the head. And now we'll talk about the spine. And so I talked about the neck and the rest of the spine separately because we pay special attention to what we call the cervical spine, which is the bones of the neck. Because everything else is pretty well supported by either the rib cage or the muscles of the abdomen, but the neck is sort of like wedged in this narrow tube. You've got some supporting muscles, you've got your windpipe in the middle, but there's really not a whole lot of substance holding up, the bowling ball of your head to the rest of your body. And so we see a lot of different sorts of injuries happen, especially with high mechanisms of injury and high amounts of force involved, like car accidents and falls from height, where your neck sort of gets whipped around and bad things happen. So the spine consists of a series of separate bones called vertebrae. So each one of these little bones, labeled with a number and a letter, each one of those is its own separate bone, and it's all connected together with ligaments. And so the spinal cord is housed sort of in between the process, which is the part with all the pokey outy bits, and the body, which is like the big structural component. There's a channel, and inside that channel is the spinal cord. And the spinal cord is a group of nerves that carry messages to and from the brain, and it passes through the hole in the center of each vertebrae. The spine is the primary support structure for the entire body. If you didn't have a spine, you wouldn't be able to stand up. And the spine has these 5 major sections. So we have the cervical spine, which is your neck. We have the thoracic spine, which is your upper back. And we're going to talk more about the thoracic cavity when we talk about breathing and rib stuff. We have the lumbar spine, which is your lower back. And this is the thing that you will inevitably pull when you turn 30. And then we have the sacrum and the coccyx. And the sacrum is sort of the back part of the pelvis. And these are not individual vertebrae. Maybe they were at some point tens of thousands of years ago. But ever since we've been human, these have all been sort of bound together, fused together. And then we have the coccyx, which is our tailbone. And so we used to have tails, because these are the bones that prove it. But our tails got really, really small, and all the bones fused together, and now we just have this sort of vestigial bone structure where the tail used to be. And that is called the coccyx. And so your sacrum and your coccyx are, again, all fused together. They're all one big bone that make up your pelvis. So let's talk about the places where bones attach to the body. So again, each pectoral girdle or shoulder girdle supports an arm and consists of a collarbone in the front, which is also known as your clavicle, and then a shoulder blade or scapula in the back. So you have your collarbone in the front, you have your scapula on the back, and then you have a bunch of bones that sort of form the shoulder, and your arm sticks out of your shoulder. So the upper arm has one bone. It's called the humerus, or the funny bone, right? And if you've ever bumped your funny bone, it's because there's a nerve that travels through your elbow and is exposed when your arm is in sort of that 90-degree position. And if you hit it just right, you can just flick that nerve, and it sends that signal up that nerve and causes you to not feel so great. But funny bone, humerus, yep, that's what it is. And then the forearm has 2 bones, the radius and the ulna. And so we call it the radial artery because it follows the radial bone, or the radius. And so again, the radius is on the thumb side, and the radial artery runs along the radius. And on the other side, you have the ulna. This is the bigger of the 2. The radius rotates or radiates around the ulna, so that's the bone that doesn't really move a whole lot when you twist your wrist. And then connected to this is your wrist, right? And the wrist isn't a bone. The wrist is a joint, and the wrist is the joint between the radius and the ulna, and all of the little bones that form your hand. So you have a bunch of bones in your palm, you have a bunch of bones in each finger, and it's all held together with a bunch of ligaments. So moving down, we have the skeleton of the chest. This is also known as the thoracic cage or the rib cage. And this consists of the thoracic vertebrae in the back, which you can see sort of in the picture going up the back. And then you have the ribs, which are attached to the spine in the back. And then in the front, they turn into a little bit of cartilage, and then that cartilage attaches to the sternum in the front. And so the rib cage provides bony support for the walls of the thoracic cavity. and this is going to be really important later. The ribs in the sternum form the rib cage. The thoracic cage protects the heart, lungs, and other internal organs. It also serves as a base for muscles involved in respiration. That's really important. The ribs, otherwise known as costal bones, but ribs are long, curved, flat bones that originate on or between the thoracic vertebrae in the end. They originate from a vertebrae, right? So they're attached to the sticky out portions of the vertebrae in the back, and then they swoop around and attach to the front, attached to the sternum or the front wall of the thoracic cavity. So every human, regardless of their sex, has 12 pairs of ribs. The first 7 pairs are called true ribs. And these ribs connect directly to the sternum. So they start at the spine, they swoop around, and they each individually connect to the sternum. And these are called true ribs. And they are connected by these cartilaginous extensions, right? But we call them true ribs because they come in and they connect directly to the breastbone. Ribs 8 through 12, these ones down here, are called false ribs because they don't attach directly to the sternum. The cartilage of these ribs merge together before they reach the sternum. And then the last pair of ribs, 11 and 12, down here you can see sort of poking out the bottom. These are called floating ribs because they don't connect to the sternum in the front. And so that could potentially, cause some issues if they get knocked loose or dislodged in some way. The adult sternum or breastbone is the flat bone in the front, and this forms the anterior, so a little bit of medical terminology there, the anterior midline of the thoracic wall, which just means front and center. The sternum has 3 parts. So at the very top here, we have something called the manubrium, and you don't have to remember that for the test. It's not going to be on your test. But if you hear it referred to, it's called the manubrium, and you have your little sternal notch that you can feel up in the top here. And then your clavicles attach to that and then sweep out to your shoulders, right? And then also your first rib attaches to that. And then down below that, we have what we think as the breastbone. This is also called the body of the sternum. And this is where most of the other ribs are attached. And then down at the very bottom, we have what's called the xiphoid process, which is the smallest part of the sternum. And it's attached to the bottom of the sternal body. The diaphragm, which is that breathing muscle, the rectus abdominis muscles, which are your abs, these all attach to the xiphoid process. And so its connection to the sternal body can be pretty easily broken by impact or strong pressure. And that creates a sort of spear of bone that can dig into the internal organs. So what we see most often is that it can either lacerate your liver, which sits right underneath your rib cage in that general area, or it can dig into the diaphragm and lacerate that, or lacerate some of the other soft tissue under there. So the xiphoid process is used as a palpable landmark during the administration of CPR. So we know that if we feel the xiphoid process sticking off the bottom of your rib cage, you're too far down, right? So CPR training strongly emphasizes proper hand positioning on the lower half of the breastbone above the xiphoid process, and I put a red dot on the screen here, to reduce the chances of breaking ribs or detaching the xiphoid process, right? So that's important. You can tell because I spent so much time talking about it. All right, so let's talk about the pelvis, and then we'll do some checks on learning. The pelvis links the body and the lower extremities. If you didn't have a pelvis, your legs would fall off, or they'd just sort of flop around like a rag doll. The pelvis protects the reproductive organs and the other organs located in the lower abdominal cavity. And the lower extremities consist of the thigh and the leg. Your thigh bone, also called your femur, is the longest and strongest bone in the entire body. The thing is massive. The leg consists of the lower leg consists of two major bones, the tibia and the fibula. And I actually have those switched on the screen. So I'm going to fix that because that's terrible. Tibia and fibula. Very important. And that will forever be in the recording of this lecture. So again, lower leg consists of the tibia and the fibula, plus the ankle and the foot. And then in the middle of these two, you have the kneecap or the patella. And this is a small, relatively flat bone that protects the front of the knee joint and also helps in moving your leg. So again, the pelvis is a protective bony structure that surrounds the essential organs in the lower abdomen. And then, like we talked about, red blood cells are manufactured primarily within the spaces inside the bones called the marrow. All right, so let's do a little bit of check on learning here. And anyone who's feeling brave can answer these questions. All right, so who wants to take one of these questions? Tell me what number you're answering and give me the answer for it. Anyone can come off mute. Be brave, I dare you. George, what do you got?
Axial skeleton is the head, the spine, and the ribs.
Where's my notes? All right, so name the bones of the axial skeleton, number 2. So would you say the head, the neck?
The head, the spine, and the ribs.
Perfect. Absolutely. Yeah. So your skull and the associated bones, cervical spine, the vertebral column, and your rib cage. Absolutely perfect. So 1 point to George. Who else wants to answer 1, 3, or 4?
I'm going number 3.
Oh. I think Melissa was up. What do you got, Melissa?
For number 3, if you damage the xiphoid process, you can damage the liver, you can puncture the diaphragm, you can cause all sorts of damage because it's a sharp, pointy little guy.
Absolutely. Don't stab your patient with their own body. Great advice. All right, 1 and 4. Who wants to take a shot?
The 5 major functions of the skeletal system. It gives the body its shape. It protects your body. It, I don't know. Yeah, I'd say there's 2 right there. I know bones hold like minerals and stuff, right?
Yep. 2 more. You got this.
It allows you to, walk around and do things, because without your bones, you'd be just like this pile of stuff.
Perfect. 1 more.
Also, it's got something to do with the blood, but there you go.
What do you think it does to the blood?
It makes stuff. Right?
Yes. Absolutely. Yeah. Absolutely. You nailed it, man. Absolutely.
I'm sure I read that somewhere in my lifetime, but man, don't remember.
Yep. So it provides support and gives our body shape. It's a storage for minerals like calcium and phosphate. It makes blood cells in the marrow. It provides protection. So the rib cage and the pelvis and the skull protect all of the important squishy bits. And then it provides leverage so that our muscles can move us around. Absolutely perfect.
Drink your milk.
Really, really good job. All right. Who's got number 4?
I think I have it.
All right. I think Reagan has it as well, but give me what you got.
So if you're in the the lateral position, so that would be on the outside. I'm going to go with radius.
Absolutely. Crushed it. Yes, absolutely. The radius. So lateral means away from the midline or to the outside. And remember that the thumb is facing outward in the anatomical position, and the radial bone is connected to the thumb. Think radial arteries on the thumb side. So that's exactly right. You guys are just crushing it. Awesome. So let's move on to muscles. So, and here we see someone in the anatomical position. It's like I planned it. All right, so muscles. Muscles provide both support and movement. Muscles are attached to bones by tendons and cause movement by alternately contracting, which is shortening, or relaxing, which is lengthening. So muscles can never push, they can only pull, and we have sets of opposing muscles that allow us to move our body back and forth. So the musculoskeletal system gets its name from the coordination between the muscular system and the skeletal system. So without the skeleton, muscles would just be squishy balls of gelatin, and bones without muscles would, well, they just hang there like they do in the store at Halloween. So they are not much without each other. So movement occurs at joints and only at joints unless you are broken. And joints are where two bones come together. Bones are held together by ligaments, which are thick bands that go from one bone to another. They span the joint and insert into the adjacent bone. So you have three different types of muscle in your body. You have skeletal muscle, which is also called voluntary muscle. You have cardiac muscle, which, as the name implies, comes from the heart. And you have smooth muscle or involuntary muscle. These are muscles you can't control. So voluntary or skeletal muscles are attached to bones and can be contracted and relaxed by a person at will. And so these are the muscles that are primarily responsible for the movement of the body. And then you have involuntary or smooth muscles. And these are found on the inside of the digestive tract. They're wrapped around the airway passages in the lungs, and they're in a lot of other internal organs all throughout the body. And these are not under conscious control, and they perform their functions automatically by contracting and relaxing according to signals from the nervous system, right? And so there's a lot more to that, and we'll talk a little bit more about smooth muscle when we talk about asthma and things like that. And then finally we have cardiac muscle, and this is muscle only found in the heart, right? It's the only place where we find this type of muscle. And it's interesting because it never stops working under normal conditions. It never stops working, but it requires a lot of oxygen in order to survive. So this is one of the few muscles in your body that just never tires out unless you get very, very sick. All right, so let's talk about mechanisms of musculoskeletal injury. So you have to understand a variety of mechanisms of injury, or MOI. That is how injuries occur. So musculoskeletal injuries are caused by a few different types of MOI. So we have direct force, which is where something impacts you directly. We have indirect force, which is force being directed through our body and damage resulting internally from things that didn't directly hit us. And so we see here she's hitting her knee on the dashboard of the car, but her pelvis is dislocating even though she didn't hit her pelvis, she hit her knee. So that's a direct and indirect force. And then we have twisting forces, like this gentleman who is, I presume, just learning to ski. The season's done for him, though. All right, and so we want to use the information provided by dispatch and gathered from scene size up and our general impression in order to identify the possible mechanisms of injury. So a word about terminology. There are lots of different ways to describe a patient's injuries. And you can use your senses of sight and touch to determine the type of injury. So again, as we feel, we're feeling for like crepitation, which is the crunchiness of broken bones. We can feel for swelling. We can see obvious deformities and things like that. We're also listening to the information that the patient gives us and other sorts of things like that. We don't have the training and we don't have the tools to diagnose an injury in the same way that a doctor can inside of a hospital. So a doctor goes through years of education. They have access to x-rays and CAT scans and all sorts of things where they can make a definitive diagnosis. But even though we're not expected to diagnose these injuries, the patient's signs and symptoms will lead you to suspect that a certain injury is most probable, right? So you know that you have a shoulder joint, an elbow joint, and a wrist joint. And if they have any more bends in their arm besides those three, you can be reasonably sure that they have a fracture somewhere in their arm, right? So we can use our good common sense to figure out what's going on. The most important part of your job is to provide the best assessment possible and then treat whatever you think is going on appropriately. All right. So let's talk about the three major types of musculoskeletal injuries that we will come across, which is fractures, dislocations, and sprains and strains. So all three types of musculoskeletal extremity injuries are serious, and they all have to be identified so that appropriate medical treatment can be provided. So let's talk about fractures first. A fracture is a broken bone, right? A fracture is any physical disruption in the structure of a bone. And we'll talk a little bit more about fractures in just a second. So there's a variety of mechanisms that can cause a fracture, but a fracture most often occurs as the result of some sort of significant force coming in contact with a bone. And fractures are classified as either closed or open. In the most common type of fracture is a closed fracture. The bone is broken, but there's no break in the skin. There's no open wound. It is a closed fracture because there is no open wound. In an open fracture, the bone is broken and the overlaying skin is lacerated. So the open wound can be caused by a penetrating object, or the fractured bone end itself can be protruding through the skin. And really our big concern here is first bleeding, but then second contamination by dirt and bacteria, which may lead to an infection. Both open and closed fractures injure the adjacent soft tissues, resulting in bleeding and swelling at the fracture site. And then fractures can also injure nearby nerves and blood vessels. And so these can be pretty serious. Next, we have a dislocation. And so a dislocation is a disruption that tears the supporting ligaments of the joint. So the bone ends that make up a joint will separate completely from each other and can lock in a different position other than the position that is useful for the patient. And so what we see is that any attempt to move a dislocated joint is very painful for the patient. And a dislocation can damage nearby nerves and blood vessels. So when you pop something out of joint, and here we see the illustration on the screen is a shoulder joint. And so we have the clavicle in the front here, and we see the shoulder blade in the back. And then this joint right here is where the shoulder should be. And so what happens is the shoulder will pop out and move forward. Is what we call an anterior dislocation, as an example. And when this happens, you can pinch off blood vessels, you can stretch out nerves, and this is very, very painful. And if it's out of position long enough, you can pinch off those blood vessels, or you can cut off those nerves enough to have a long-term disability. Right? So these people need to be transported to an emergency department so they can have this dislocation reduced, which is another name for putting it back into its socket. And generally speaking, a physician or another highly trained provider is going to reduce these back into position. And these folks generally use a lot of pain control as well. So finally, we have sprains and strains. So a sprain is a joint injury caused by excessive stretching of the supporting ligaments, and it can be thought of as sort of a partial dislocation, right? So the bones don't come out of joint, They stay in joint, but what you're doing is you're stretching and you're tearing all of the supporting connective tissues that hold the joint together. So a sprain is excessive stretching of the supporting ligaments. Strains are caused by stretching or tearing of muscle. And so at this level, you will not be asked to differentiate between a sprain and a strain. Just note that it involves the stretching and tearing of the supporting tissues, whether those are ligaments or tendons and muscles, things like that. So what happens when you break stuff, dislocate stuff, or sprain or strain stuff? And so signs and symptoms include, obviously, pain at the site of the injury. In the instance of an open wound or an open fracture, we'll have some kind of open wound. Swelling and discoloration. So we see in the middle there, we have some bruising from what is probably a sprained or strained ankle there. Deformity. So we see that this person has an extra wrist there. It's not an extra wrist. It is a broken radius and ulna bone there.
Broke that.
What's that?
That's the bone I broke.
Yeah. How did you break it?
Nah, I'm not gonna talk about it.
Did you fall forward and try to catch
I
yourself?
fell off of something, and when I fell, I put it to my chest, and it kind of I landed on a bunch of rocks and pebbles, and I will get back up, and I have this big, large indent in my wrist, and that went from there.
Okay, so you didn't reach out to catch yourself, you landed on it?
Yep.
Okay.
They were
So,
both.
so when someone reaches out to catch themselves, which is sort of the instinct, that's one of the really common mechanisms where they'll put their hands out to catch themselves, and then they'll break their wrists. And we call it a foosh, a fall on outstretched hand. It's one of the many things in medicine that we have a clever name for. So when you hear someone has a foosh injury, it's fall on outstretched hand.
That's what my wrist looked like, Catherine. Pretty accurate.
Yep, absolutely. And there's lots of clever names. But we see here deformity, angulation, and obviously, were you able to move your wrist around after you broke your arm?
Yes and no. I was in the hospital flinging it around, but...
Oh, that's terrible. That's disgusting.
Yeah, my mom was not happy with me.
So generally speaking, when you break a bone, you lose the function of the limb below the level of the break.
Oh. So my son ended up doing that to his. He jumped off a chair following his sister, and his foot hung up on the trash can, and he went to go catch himself, and that's how that happened. He was holding his arm, but me being a frightened mom didn't know. I feel absolutely terrible, but I think I made it worse because I was like, what's wrong, like holding his hand. And I think I made it worse, but they fixed it. It was both bones in his arm completely broke.
Yeah, mine were both bones, and actually the way that they described it at the hospital is if I wouldn't have told the actual story, they were going to call it DCYF because of the way it looked. It looked like she had taken my wrist and twisted it, just all the way around twisted it, and that's what it looked like. And if I hadn't told the truth, my mom would have gotten some serious trouble.
Yeah, well, and we'll talk about what the appropriate management of a fracture is, but your first instinct, generally speaking, when you break something, is to cradle it. Is that what you did when you broke it? Did you sort of hold your wrist?
Yeah, I held it real close to my chest.
Right, exactly. And we're going to translate that instinct into your medical intuition, but what we're going to do is we're going to immobilize a broken bone or apply what's called a splint. And so we'll talk more about that in a little bit. So a word about standard precaution. So again, this is part of our scene size up. We want to apply the appropriate personal protective equipment. And so patients with musculoskeletal injuries may have open wounds. And then we always want to assume that trauma patients with open wounds pose some sort of threat of infection. And so we always want to wear appropriate gloves. when you're responding to motor vehicle crashes or other situations that present a hazard from broken glass or jagged metal, we want to wear heavy rescue gloves, bunker pants, and other PPE like that. Some rescuers will wear their nitrile gloves under the heavy rescue gloves for added protection, because your rescue gloves are meant to prevent abrasions and cuts, but they are not impervious to liquids and things like that. So the blood and any blood-borne pathogens will soak through your rescue gloves. So if the patient still has active bleeding that may splatter, you should think about eye protection, covering your mouth and things like that. Something that a lot of us will do anyway nowadays, but just assume that you're going to catch something and protect yourself appropriately. And so once again, we are following this systematic method of assessment. So scene size up, we're doing our ABC primary survey, D for update, dispatch, or update the responding units. And then we're going to launch into an appropriate secondary assessment. So in this case, we are more concerned about our secondary physical assessment for this patient than we are about history taking, because for the time being, we have physical trauma concerns, and we want to address those first. So we're absolutely still going to take a sample history, but we're going to do our head-to-toe assessment first. So all the steps in the patient assessment have to be carried out before focusing your attention on an injured limb. Limb injuries are not life-threatening. Unless there's some kind of excessive bleeding coming from an open wound, which you would address when you address bleeding control, unless that's the case, there is no broken bone in your body that presents an immediate life threat. And so we're going to stabilize the patient's airway, breathing, and circulation first. And then, once we know that the patient isn't actively dying, we're going to address other concerns, such as splinting. And so we have a saying in EMS, don't splint your patient to death, which is exactly what you will do if you see a broken bone and you immediately jump to applying a splint and you forget to open the airway, you forget to make sure they're breathing, you didn't notice that they didn't have a pulse, and you failed to apply CPR for like the 10 minutes it took you to build a splint. So don't splint your patient to death. Make sure that you are conducting your primary survey and assessing and managing airway, breathing, and circulation first. So that said, when we examine the injured limb, we want to inspect the injured limb and compare it to the opposite uninjured limb, right? So does this limb look like their other one? And if it doesn't, is that normal for you, right? So if their leg is slightly shorter on one side, is that a broken pelvis, or do they just have one short leg, right? Gently and carefully cut away any clothing covering the wound, right? So if you have a broken arm, or if someone has a broken arm, the last thing you want to do is put their arms up over their head so you can take their sweater off, right? That would be terrible. Instead, try to gently cut away the clothing to expose the wound, especially if there's some sort of open wound. When you examine the limb, you may find one of the following: so open wounds, deformities, swelling, bruising, sort of all of the evidence that something bad is happening underneath. You want to gently feel the injured limb for any points of tenderness. Tenderness is one of the best indicators of an underlying fracture, dislocation, or sprain. To detect a limb injury, start at the top of each limb, and then using both hands, cup the arm and squeeze the entire limb in a systematic, firm manner, moving down the limb and away from the body, right? And what we're searching for is the instability or crepitation, which is the bones grinding together. And if you ever want to know what crepitus or crepitation feels like, the next time you're out getting some chicken wings, take a drumstick, break it in half, or really any bone, break it in half, and then feel what the bones grinding together feels like before the meat is taken away, right? So while the meat is still on the limb, break the bone on the inside. And that's sort of what crepitation is like. So as you conduct the hands-on examination, ask the patient where it hurts the most. The location of the greatest pain is probably the injury site. Ask the patient if they feel any tingling or numbness in the extremity. If they do, this may indicate that there's some kind of nerve damage or that there's some sort of pinching off of the circulation. So after you've made a careful visual and hands-on examination, and if the patient shows no other signs of injury, ask the patient if they can move the limb carefully. If there is an injury, the patient will report pain and refuse to move the limb. People with broken bones tend not to move them. All right, so if the patient can't move their fingers, their wrist, and their arm voluntarily, because remember, when we rotate our wrist, we're actually moving all of the bones of the lower arm, right? So, and you can feel this if you wrap your hand around your wrist and then rotate, you can feel the bones rotating underneath your hand. So if you suspect a limb injury, you have to evaluate the circulation and sensation of that limb. And so here we have a lower extremity. So we're feeling for the circulation in the big artery that runs behind the heel, the sticky outy bit of the heel, right? There is an artery in there. If you can feel it, great. If you can't, what's another way to see if there's circulation in a part of the body?
Capillary refill.
Exactly.
Yeah.
Yep, cap refill. And so you can see he's checking sensation, pinching a toe. Hey, can you feel this? But at the same time, you can pinch the exposed toenail and see the capillary refill there. And so again, if there's a delay in capillary refill, if it takes a couple seconds for the blood to get back, or if it stays pale after you squeeze it, that's an indicator that circulation is impaired in that limb. So all limb injuries are treated in the same way in the field, right? We're going to, any open wounds that we see, regardless of whether they have a bone involved or not, we're going to perform bleeding control to. So we're going to cover them with dry sterile dressings. We're going to apply firm but gentle pressure to control bleeding. If that doesn't work, we're going to upgrade to a pressure dressing, just like we talked about during bleeding control. We can apply chemical cold packs. So those cold packs where you break the pouch in the middle and you shake it up and they get really cold. We can apply those to painful, swollen, or deformed extremities. But keep in mind that we shouldn't apply them directly to the skin. We shouldn't apply them for more than 10 minutes because we don't want to cause a cold injury to the tissue. And then we should apply a splint to the injured limb. And so we'll talk more about that. So some general principles of splinting. All limb injuries should be splinted before the patient is moved unless the environment is dangerous. Splinting prevents the movement of the broken bone ends. And so again, if there's sharp, pointy ends of broken bones inside the tissue, when they move around, if you were to grab the wrist and sort of shake the arm around, you're moving those bones around and they're tearing up and causing that tissue inside to be inflamed. You can also cut open a blood vessel that wasn't injured before, or slice a nerve, which takes a really, really long time to heal. So we want to minimize the amount of movement, and so we want to splint the person before we start moving them around. And then by reducing movement, it also helps to control pain. Splinting helps control bleeding and decreases the risk of additional damage. And then splinting prevents closed fractures from becoming open fractures, because the worst thing you can do is take an injury and make it worse by stabbing them from the inside. So don't do that. So we want to remove the clothing from the injured limb to inspect for open wounds, deformity, swelling, bruising, capillary refill. We're testing for circulation and sensation before we do anything. And then once we check for circulation and sensation and we've done all bleeding control, we can then start to apply a splint. So the golden rule, the golden rule of splinting, is that the purpose of the splint is to immobilize the joint above and below the site of the injury. All right. If you remember nothing else about splinting, right? If you need one golden principle, one guiding rule, a splint immobilizes the joint above and below the site of the injury. All right, so I'll ask you this. Can you break an ankle? It's a trick question.
Break bones in an ankle.
What's that?
Well, your ankle's a joint, right?
Your ankle is a joint, yes. So can you break a joint?
You break. You
No.
tear a ligament.
You can sprain it, you can dislocate it, but can you break it? Can you fracture a joint? Can you fracture the space between two bones?
No.
No, you cannot, right? Because a fracture is a broken bone. So you cannot break an ankle. However, you can break the distal most portion of the two bones in your lower leg, right? Your tibia and your fibula. You can break those. And if you break them low enough, people are going to call it an ankle, a fractured ankle, right? You can also break the bones of your foot, right? So there's a bunch of bones that form the joint of an ankle, and you can break those as well, right? But you cannot, if we're being medical about it, we cannot break an ankle. So if we're immobilizing the joint above and below the fracture, if we break the bottommost portion of the tibia and the fibula, just above the ankle, what two joints are we going to immobilize?
The knee joint, and then I guess the ankle joint.
Yeah, exactly. For a broken ankle, we're going to immobilize the knee and the ankle, right? So by immobilizing the ankle, we're sort of immobilizing the whole foot. And with the knee, we have to make sure that we go up high enough on the thigh that the knee doesn't bend, right? And so, absolutely, that is absolutely correct. And we'll get some practical experience with this weekend when we dig out all of the splinting supplies. And so you guys are going to have a lot of fun tying each other up in interesting ways. And so just to address the ball and socket thing, there's only there's two ball and socket joints in the body. It's the hip and the shoulder. There's no ball and socket in your ankle. It's more of a hinge. All right, so immobilize the joint above and below the site of the injury. Padding is super important. In wilderness medicine, we have a clever little acronym called BUFF. We want to buff out all of our splints. And so BUFF stands for big, ugly, fat, and fluffy. All splints need to look big, ugly, fat, and fluffy. If they're not like pillows and towels and like big old air splints, like all of these splints are really fluffy, and the reason for that is we want to limit the amount of movement that gets into the joint, right? So they have to be big and fluffy in order to minimize the movement of the limb after splinting. And then, so you're going to gather your materials, you're going to build your splint, and then you're going to apply it to the limb. Right? So we don't sort of layer things onto the limb and as we collect them, because we want to minimize the amount of movement and thus the amount of pain and damage we do to the patient while we're putting this on. So a lot of times they're going to either stabilize their own limb, or you're going to have a partner stabilize their limb, and then you're going to build the splint and you're going to apply it. And so there's a couple different types of splints. We have rigid splints. These are like SAM splints once they're curved. Because remember, a SAM splint is just a floppy piece of metal until you put a curve in it. And then we have boards and padded cardboard and all sorts of stuff. And then there's soft splints. This is like a towel or a pillow. You can use a commercial device like this air splint or a vacuum splint, and those work really well. And then you'll also hear something called a traction splint. And so this is something that requires 2 trained emergency medical technicians or higher. So EMRs are not going to be putting on traction splints. You may at some point be asked to assist a couple of EMTs putting on a traction splint, something like holding manual inline stabilization or something like that. But a traction splint is specifically for a femoral fracture. And this is something, again, put on by an EMT. All right, so it's been about an hour. So let's cut out for about 10 minutes, take a 10-minute break, and come on back at 7:15. Okay, so let's talk about injuries to the shoulder girdle. So the easiest way to splint most shoulder injuries is to apply a sling. In this case, it's made by a triangular bandage, but you can also get commercially manufactured slings. And then to secure the sling to the patient's body with something called a swath. And so we're going to demonstrate this skill this weekend, but effectively what you're doing is you are supporting the patient's arm with the wrist slightly higher than the elbow, and then you are strapping that arm to their body so it doesn't chicken wing around, right? So their elbow can't go flopping around anywhere. And so I will tell you that in this picture here with the swath applied to this person, this is the most ineffective swath that you can put on someone because it doesn't do what we apply swaths for. The elbow can still move down here. And so we'll teach you a couple different ways to secure that so it's actually functional. So for shoulder dislocation, one of the things we can do in addition to a sling and swath to make the patient more comfortable is placing a pillow or a rolled up blanket in the space between the upper arm and the chest wall, sort of up in the armpit area. And then we'll apply the sling and swath as we will practice on Saturday. For elbow injuries, don't move an injured elbow from the position in which you found it, although generally speaking, the position that you find it will be sort of that splinted position with the patient holding their arm. The elbow has to be splinted as it lies because any movement can cause additional nerve or blood vessel damage. So once it is in the position that you find it, keep it in that position. So an effective splint for an injured elbow is, again, one of these pillow splints. If you can't find a piece of equipment in the ambulance that fits the shape of the elbow exactly, a towel or a pillow, something like this is going to be really helpful. So wrap the elbow in a pillow, add padding to keep the elbow in the position found, and then secure it using triangular bandages or any other splinting material. For injuries of the forearm, you can use a lot of different types of splints, and so we're going to have padded board splints and SAM splints this weekend, but you can also improvise using any sort of rigid device. So I've seen, again, not so much the rolled newspapers and magazines, but I've seen cardboard used and a variety of other things, ski poles and all sorts of stuff. For hand, wrist, and fingers, these generally don't need super complex splints. The functions of these bones, because there's so many of them, the function of the bones is complex, and if poorly or inadequately treated, it could result in permanent deformity or disability. A lot of times these patients need to go to what's called occupational therapy, which is therapy for the parts of your body you use for occupations, like hands and feet and fingers and toes. But generally speaking, you can use bulky hand dressings, a short piece of splint, a roll of gauze to immobilize these injuries of the wrist, hand, and fingers. If there is an amputation, then again, we're going to collect up any amputated pieces and we're going to place them in a sealed bag and try to keep the pieces cool as they get transported to the hospital with the patient. And again, any open wounds we're going to cover with dry sterile dressing. We want to try to place these injuries in what's called the position of function. And so the position of function is sort of the palm facing in towards the body, the hand slightly cupped, and the wrist slightly bent or slightly flexed, right? That is the position of function, sort of what we would imagine as the fetal position. If you curl up in the fetal position, that position that your arm sort of naturally finds its way into is the position of function for the most part. And so if we can get their hand into the position of function, especially with the fingers slightly flexed in, that would be ideal. So for pelvic fractures, fractures of the pelvic often involve severe blood loss because of broken bones. And these broken bones are where a lot of very large blood vessels are running. And so the major blood vessel that runs down the center of your body, called the aorta, splits into two right around where your belly button is. And then those two femoral arteries are just enormous. You can bleed out from one of these arteries in just a few minutes. And so it's really important that we treat patients with suspected femur fractures in a very gentle manner. Pelvic fractures commonly cause shock, and we want to treat the patient for shock, but don't raise the patient's legs or don't manipulate their lower body unless they have like a pelvic splint on, which is not something we're going to learn how to apply. The most definitive sign of a pelvic fracture is tenderness when you use your hands to compress the patient's pelvis. And so when we move patients with suspected pelvic fractures, we want to use one of those scoop stretchers or scoop backboards that come in two pieces. And there's a lot of different types of these devices. And so what I recommend is whatever department that you are a part of, see what they have for their scoop device and practice with that device, because while they all have a similar mechanism, they're all going to work a little differently. So get with the folks on your department and get your hands on these scoop stretchers so that you can work as part of a team to put these together, because it is definitely a more than one rescuer task. So in general, hip injuries, again, they're either fractured or they're dislocated. Both injuries can result from high energy impact or trauma, either direct or indirect impact. Hip fractures occur at the upper end of the femur rather than in the hip joint itself, because again, you can't fracture a joint. So either your pelvis is fractured or your femur is fractured. But because of the way the femur is constructed with that ball and socket up at the top, you can shear off parts of that bone that are way up high by the hip. These fractures are often more prevalent in elderly patients because their bone weakens and becomes more fragile over time. This is a condition called osteoporosis, where osteo refers to bone and porosis refers to the decreasing of bone density. Fractures of the hip region usually cause the injured limb to become shortened and externally rotated, which means that one leg will be shorter than the other, while appearing to be perfectly straight, it'll be shorter. And then one foot will be rotated outwards, right? And that's a sign that you have broken either the pelvis or the proximal femur. That's the high up on the femur. A dislocated hip is extremely painful. The joint is usually locked in that position with the thigh flexed and rotated inward, right? So because of the way that the ball pops out, the ball of the joint is going to pop out backwards towards the back of the body. And so again, you'll see the 2 feet, and one will be shorter and then rotated inward towards the body. And that's how you can tell the difference between a fracture and a dislocation in that regard. You won't be required to know the difference, but just know that you need to look for that the shortening of the extremity and the rotation either inward or outward as a sign of either a fracture or a dislocation. And so regardless of whether it's a fracture or dislocation, you want to treat all hip injuries by immobilizing the hip in the position that you find it in. So you can use pillows, rolled blankets. You can place the patient on one of these scoop stretchers to move them to the ambulance cot and then take them off the stretcher. And then an elderly person who has fallen and reports pain in the hip, thigh, or knee should be splinted and transported to the hospital because there's a high likelihood that they have some sort of dislocation or fracture. So injuries to the thigh. A fractured femur is very unstable and usually produces a significant thigh deformity with a lot of bleeding and swelling. One of the last times I saw this, it was a person who fell asleep at the wheel and crashed their car into a tree. And as they drove off the road, they woke up and they immediately slammed their foot on the brake. And when the car hit the tree, the force of that impact was projected up through their leg. It fractured their femur, and their femur came out the side of their leg. And then as everything relaxed, it retracted back inside. And so one side of this person's body, one leg as compared to the other, was just enormously swollen by the soft tissue disruption and the amount of blood collecting in that broken leg. So that would be a really good sign that you have a fractured femur, is if one of their legs looks like they never skip leg day in the gym and the other one is, relatively normally sized for that person. In any case, you want to place this patient in whatever position that is comfortable for them. Treat them for shock because of the amount of blood that you can lose into that compartment of your body. They may go into shock, and then be prepared to move this patient quickly to the ambulance and get them to a hospital. You can secure both of the patient's legs together with something called anatomical splinting, right? So instead of using a backboard and then tying them down to the backboard, you can tie their legs together and use one leg as a splint for the other. You can also use a piece of splinting material in between the legs in order to immobilize them. This is one of those injuries where a traction splint would be applied, but again, that is something that the EMT level and above are trained to do, and we just don't have the time to go into all of the anatomy in order to effectively perform that procedure. So you should know how to use the traction splints so that you can assist other EMS personnel in their application. And this is something that you're going to be doing when you get to your department. You'll be training on these pieces of equipment. And so here we see the manual stabilization of a leg that we presume to be fractured. And then once the EMTs arrive, they're going to straighten the leg and they're going to begin pulling traction. And so this is one of several ways to apply traction. This is sort of an older way. There's a lot of traction splints that don't require this technique anymore. And so again, it's not something that we can go into in depth, but once you get to your departments, whatever traction splints they have, you'll learn to use that particular traction splint because there are 5 or 6 or 7 different splints on the market and they all work slightly differently. So whatever your department uses, make sure that you're familiar with that. So knee injuries. This is another one of those joints where you're going to immobilize it in the exact same position that you found it. And the reason why with elbows and knees we do that is because they're relatively complex joints and they have lots of nerves and blood vessels going through the joint. And so just like if you've ever knocked your funny bone, when you have your elbow slightly bent, you can sort of get in there. There's the nerve. There's the nerve that runs through the joint in that case. And so you also have nerves running through your knee. So you want to immobilize these in exactly the position that you find them in so you don't cause additional injury. And so here we see the padded board splints and we see the use of the triangular bandages for splinting material. And we'll get to do more of that this weekend. If there's significant deformity, we can place pillows, blankets, or any sort of fluffy material underneath the knee to keep it in the position. Secure with any material that you have, and then place this patient on a stretcher or the cot in the ambulance. We don't use backboards anymore except to lift and move patients. In general, fractures of the legs can be splinted using a lot of different devices. We'll get into it this weekend. It generally takes 2 or more trained people to perform a splinting skill, and you'll see how important that is this weekend. Ankle and foot fractures, generally they're splinted with either a pillow or an air splint. You can do it with a SAM splint. Again, as long as we understand that we're immobilizing the joint above and below the site of the suspected fracture, you'll do just fine. Splinting is a skill. It is absolutely a skill that needs to be practiced. It is a perishable skill. So this is something that you should train on relatively often. And remember, before and after applying a splint, you have to recheck circulation and sensation. All right, so make sure you check for circulation and sensation before you apply the splint, and then once you've applied the splint, check it again. Does anyone know why you want to check circulation and sensation after you apply a splint?
To make sure there's blood flow.
But why before and after?
To make sure you didn't cut off blood flow with the splint.
To make sure it isn't too tight.
Yeah.
Right, so not only to make sure it wasn't too tight, but inevitably there's going to be some movement when you are applying a splint. It's almost impossible not to move the limb while you're applying a splint. And so you want to check to make sure you didn't make the whole thing worse by moving it around, right? If we apply a splint and then we no longer can feel a pulse and we no longer have capillary refill, or the patient's now complaining of numbness and tingling, something went wrong and we need to go back and reassess what we've done. So, yep, you're absolutely correct. So let's move on to the head, the neck, and the spine. So any questions on the rest of splinting before we get into head, neck, and spine? All right. So severe head and spinal cord injuries can result from a lot of different kinds of trauma. These types of injuries are a common cause of death, but if not fatal, then the types of injuries that that you can get are sometimes lead to things like paralysis, brain damage, and things like that. So again, the human skull has 2 primary parts. You have the cranium, which is a tough shell, a bone shell that protects the brain. And then attached to that, you have the bones of the face, which give form to the face and give protection to the sensory organs and things like that. And then, of course, you have the jaw attached to the face. When we talk about mechanisms of injury, head injuries are common with certain types of trauma. So it's important to understand sort of what's going on inside that bone structure. So between the skull and the brain, you have a blanket of fluid called cerebrospinal fluid. And this cushions the brain from direct blows. So it's sort of a fluid cushion. A direct force can injure the skull and the brain inside, but also indirect forces can cause injury as well. A spinal injury is often associated with head injury, especially with direct blows to the head. That force can be transmitted to the spine, producing either spine fracture or dislocation. And all patients with head injuries are at risk of having cervical spine issues. And so we should consider cervical spine immobilization if we have any sort of significant injury to the head. And so some of these types of head injury, first, in a closed head injury, the bleeding and swelling are within the skull, and they can increase the pressure that is put on the brain, leading to irreversible brain damage and death. So again, swelling inside the brain doesn't have any place to go if the pressure increases on the inside of the skull, and so the increased pressure can push on the brain and cause significant and permanent damage. An open head injury usually is associated with a lot of bleeding. Severe open head injuries are serious, not always fatal, and we want to examine the nose, the eyes, and the wound itself to see if any blood or cerebral spinal fluid is seeping out. In severe cases of open head injury, brain tissue or bone may be visible. And so here on the screen, we see open and closed head injuries. We can see sort of the forces on the skull. If you get a direct blow to the skull, we see that there's also indirect forces to the cervical spine, the vertebrae of the cervical spine. And then here we see a closed head injury, and you can see the brain is starting to swell up there as it fills up with blood. And then an open spine injury, we can see that not only is the scalp, the soft tissue on the outside of the skull, torn open, but we also have bone fractures to the cranium, and then in addition to that, swelling of the brain, which may be pushing out of that hole if the injury is severe enough. So what are some signs and symptoms of head injuries? Great question. So a patient who sustained a head injury may exhibit some or all of the following signs and symptoms. So obviously, if you get a blow to the head, you may be confused. You may exhibit some unusual behaviors. Or you may just get knocked unconscious. In some severe head injuries, there may be some nausea and vomiting associated with it. Sometimes, but not always, bleeding from the ear. And then in the worst case, unequal pupils, right? Unequal pupils is a sign that the pressure inside the skull is very, very high and they're about to have permanent brain damage. It's one of the last things you see before permanent brain damage. They may also have paralysis, seizures, and then some obvious external head trauma like a hematoma or a big collection of blood. If anyone's ever gotten sort of walloped in the head by an errant baseball or something like that, and they have the goose egg, that is external signs of trauma. In some cases, you can develop later signs, bruising and things like that. And so here we see two pictures of later signs. The first one is what we call raccoon eyes, pretty intuitively named, right? And this is a sign of a skull fracture on the inside of your skull that's allowing blood to seep out into the tissues. And then the second one is called Battle's sign, not the sign that you were in battle, but Dr. Battle named it, and so it's Battle's sign. And this is bruising behind the ear. And both of these are late signs. You're not going to see this for 12 to 24 hours after the injury. But if you're called to someone's home and during your sample history, you discover that they were in a car accident, 12 hours before, and you see, the bruising of the eyes, the bruising behind the ear, then you know that they have internal bleeding in their skull and that they should be evaluated at a hospital as soon as possible. So how are we going to treat these folks? Well, first thing we're going to do is we're going to take that neutral inline immobilization of the head and neck, right? So we're going to have someone sort of stabilize their head and neck and consider the application of a cervical collar, which we'll get into later. Then, of course, we're going to maintain an open airway. This is an instance where we'd want to use the jaw thrust and not a head tilt chin lift maneuver. If the patient is nauseous and begins to vomit, we want to be prepared with our suction devices. We want to be prepared to support the patient's breathing, either by administering supplemental oxygen or in the case of inadequate breathing, providing artificial ventilations with a bag valve mask. And then, of course, if the patient goes into cardiac arrest, we want to do CPR. Sometimes we're able to determine whether blood or cerebral spinal fluid is seeping from wounds from the nose and the ears. This is not always possible, but in some cases we can do that. We want to try to control all bleeding from head wounds with dry sterile dressings, examine for other injuries, and then promptly transport. Facial injuries, they can result from a variety of different things, and they usually bleed profusely, and they give you some evidence as to the mechanism of injury. So for example, if you come to a motor vehicle collision and you don't see an airbag, but they have lacerations to their face, then you're concerned that that they hit their face either on the steering wheel or the windshield or something else. We can also see this with, assaults, falls, a variety of different injuries. Airway obstruction is the primary danger in severe facial injuries. So when we see damage to the face and the facial bones, sometimes these bones can collapse. They can lead to collapses in the structure of the airway, which makes it difficult for us to open the airway, insert airway adjuncts, or use a bag valve mask on these folks. Also, we're concerned about the collection of blood in their airway, so we have to be ready with suction devices. So in all cases, we're trying to support breathing. We're monitoring their circulation. We can control bleeding by covering any wound with dry sterile dressing or applying direct pressure. Remember that if they're bleeding from a cheek wound, we can manage that by putting some gauze inside their cheek. But generally speaking, we do not pack the airway with anything. We're not going to stick anything in their mouth to sort of control bleeding, because by doing so, we're blocking their airway. So be smart about it. It's better to suction blood out of the mouth. And then, of course, get this person to a higher level of care as quickly as possible. If you do suspect injuries to the head and neck, and this person is vomiting or blood is collecting in their airway, one of the things you can do is apply a log roll to the patient. But make sure that you have enough people to do this safely. Again, we don't want to twist their spine, and we don't want to twist their neck. And so here we see 3 people on this person log rolling them over, and this person at the head's only responsibility is to make sure that the head doesn't flop over, is to maintain that cervical spinal immobilization. And so again, on the head person's count, she's going to do all the counting, and everyone's going to log roll the patient as a single unit. So again, it is possible that spinal injuries can cause irreversible damage, including paralysis. Displaced vertebra, which again are the bones of the spine. Swelling or bleeding can put pressure on the spinal cord, which will cause signals going through the spinal cord to stop. In severe cases, the spinal cord may be severed, although this is very uncommon. If all or part of the spinal cord is cut, the impulses can't travel to and from the brain, and without conduction of these nerve impulses, the patient will be paralyzed at that level and below. Some injuries to spinal cord. So if the injury is high in the neck, then the worst case scenario is that we paralyze the muscles that are responsible for breathing. And so if anyone remembers Christopher Reeves, he was an actor that played Superman. He fell off a horse. He had an injury high to his spine. And then, of course, he was on a ventilator for the rest of his life. Falls, motor vehicle crashes, these are really common causes of spinal injury. If we suspect a spinal injury, then we need to be very, very careful with these patients. And so one of the primary signs and symptoms that you're going to see is tenderness. And so you'll see higher level providers who are trained to rule in injury to the C-spine. You'll see them palpating along the center of the back, and what they're doing is they're palpating for spine injuries. And so a patient with a spinal injury will be able to report sort of the electrical burning sensation over a specific part. And then, of course, if the patient can't move an extremity, or if they're complaining of numbness, tingling, electricity, burning, tingling, then those are all signs that there are some sort of nerve injury. And so what are we going to do for these folks? Well, we're going to maintain an open airway. We're going to use the jaw thrust maneuver to open the airway. We're going to support the patient's breathing by administering oxygen and keeping the airway open. Again, BVM if necessary, monitor circulation, assess pulse movement and sensation in all extremities, and then we will consider applying one of these cervical spinal collars. And so we'll talk more about specifically how to apply these, but it is relatively simple. And if you forget, the instructions are literally imprinted in the plastic of the device. And so the instructions are on the device itself. And so, again, we'll go over this weekend. When we're talking about helmets, helmets are, a lot of the time, they don't need to be removed depending on the type of helmet. You only need to remove a helmet if it interferes with your management of airway and breathing. And you can remove you can remove some parts of the helmet. So in certain types of sports, you'll be able to take off like the face plates and things like that. Motorcycle helmets are generally very difficult to control airway and breathing in the full face motorcycle helmet, and so that's going to be a case where you'll need to assist in someone taking that helmet off. This is a skill that we are not going to teach. However, this is taught at the EMT level, and you may be expected to assist an EMT or higher in removing these sorts of things. So before we move on, is there any questions about head and neck injuries? So Nick asked, can we practice that if he brings a helmet? I'm going to say probably not, because we have a lot of skills to get through, and there's a lot of skills that are going to be really important for you passing the test, and removing a helmet is not one of them. However, it is a useful skill depending on where you work and what time of year you work, so I definitely recommend you practice this with your department.
Thank you.
All right, so let's get into injuries of the chest. So the chest cavity contains some pretty important stuff, your lungs, your heart, some major blood vessels. That stuff's pretty important, and we don't want it injured. And so, fortunately, we have developed a bony cage which protects all of those organs. So the cavity is surrounded and protected by the chest wall, which is made up of ribs, cartilage, and a bunch of muscles. So because of this, even a simple fracture of one rib produces a lot of pain and difficulty breathing, because our ribs sort of spread apart as we breathe in. So you'll see that a lot of people with rib fractures don't want to take a deep breath, and there's some problems associated with this. Multiple rib fractures result in significant breathing difficulty, and a patient may not be able to breathe deeply enough to take in an adequate amount of oxygen. So rib fractures may be associated with injuries to the underlying organs as well, and we'll talk about that a little bit. So to determine whether a rib fracture is bruised or broken, apply some pressure to another part of the rib. Pain in the injured area indicates a bruise or a crack, or a bruise, crack, or fracture. If the injury is to the side of the chest, place one hand on the front of the chest and the other on the back and squeeze gently. To check an injury to the front or back of the rib cage, place your hands on either side of the chest and squeeze gently. And so again, this is going to be part of your assessment of the chest when we're doing a head-to-toe exam. In patients with rib fractures, be alert for signs and symptoms of internal injury, particularly shock. And your treatment of rib fractures is generally pretty simple. We don't splint ribs. We can give the patient a pillow to hold on to that can sometimes help them, but we don't tape up fractures of the ribs or anything like that. We don't use sandbags or anything of that sort. We do want to prevent excessive movement of the patient as we prepare for transport, and we do want to deliver supplemental oxygen. So one of the interesting conditions that we can see sometimes is called a flail chest. If 3 or more ribs are broken in 2 or more places, that section becomes independent of the rest of the chest wall. And so what we see is that when we breathe in, that segment of the chest will be sucked in instead of expanding out with the rest of the chest. And when we breathe out, that section of the chest will balloon outwards instead of relaxing like the rest of the chest. And we call this paradoxical motion. And that's why it's called a flail chest, because it seems to flail in the opposite direction of breathing. But the important thing to remember here is that if the chest wall isn't moving in the direction of breathing, you're not going to breathe very well. And so a flailed chest decreases the amount of oxygen and carbon dioxide that are exchanged in the lungs, and it's going to cause a breathing problem that will progressively become worse as the patient continues to have difficulty breathing. So how do we treat this? We don't attempt to restrict the movement of the chest. So again, we don't splint, tape, or press on the chest in order to splint these things. It may be helpful to support the patient's breathing with positive pressure ventilation using a bag valve mask and supplemental oxygen if they'll tolerate it. But in general, we just want to monitor and support the patient's ABCs and make sure that we can transport them promptly to a hospital. Another thing that you'll see is and we'll see this in penetrating chest wounds specifically, but we'll see a collapsed lung. And so if an object like a knife or a bullet or really anything penetrates the chest wall, then as the patient breathes in and out, air will suck in through that hole rather than coming in through the nose and the mouth. And that's bad because we need the air to go through the airway and fill up the air sacs in the lungs where the oxygen and carbon dioxide exchange in the blood. And so if the air is coming in through the chest, it actually surrounds the outside of the lung and doesn't have access to the blood. And so we see that the lung over here is much smaller than the fully inflated lung on the other side. And that is all air that's getting into the chest but not into the lung. And this will cause a collapsed lung. And this is bad because it places the patient at risk of shock and, of course, death. So in addition to this, blood loss into the chest cavity can produce shock. And so where there's air in the lungs, there's also blood because that's how the lungs work. And so anything that's going to poke a hole in the lung tissue is also going to poke a hole through an awful lot of blood vessels. And so we can lose a lot of blood into that open space of our chest. So what are we going to do to correct this? Well, the first thing we're going to do is we're going to patch up the hole. Just like patching up a tire, we're going to cover it with something that is air-proof. And so we call these dressings occlusive dressings or chest seals. And there's a lot of commercially manufactured chest seals that work really well. But if you don't have a commercially manufactured chest seal, you can improvise with any piece of plastic that you can seal over the chest. Plastic and a lot of tape because punctured chests are very slippery. But a side effect of this is that as you breathe in and out, air from inside the lung will escape into the chest cavity and build up pressure. And when this happens, you'll notice that the patient is going to be breathing harder and harder and harder. This is a sign that you're building up pressure on the inside of the chest. And so we caused that problem by covering the hole, and we can undo that problem by peeling back one side of the dressing to let out that trapped air and then immediately covering the wound back up, right? And this is a temporary fix, and the longer your transport, the more times you'll have to burp this wound to allow the pressure inside the chest to equalize. And again, we're going to monitor for airway breathing and circulation and treat these folks for shock. One of the things that may happen is the patient's heart may stop because of the amount of blood that they've lost, in which case be ready to begin chest compressions. All right, so let's summarize and take a quick break. Musculoskeletal injuries are caused by direct force, indirect force, or a twisting force. A fracture is a broken bone. Fractures can either be closed or open. If the bone breaks through the skin, it's an open fracture. A dislocation is a disruption that tears the supporting ligaments of a joint and moves the joint out of its normal position. A sprain is a joint injury caused by excessive stretching of the supporting ligaments. And regardless of the injury, we want to assess it by performing a general assessment of the patient, examining the injured part, and then evaluating circulation, sensation, and movement in the injured limb. Regardless of the extent or the severity, all limb injuries are treated the same way in the field. For open wounds, we use bleeding control, and then the injured limb should be splinted. 3 basic types of splint: rigid, soft, and traction, and it usually takes 2 people to apply a splint effectively. Severe head and spinal injuries are the result of lots of different types of trauma. A lot of these types of trauma are fatal, but if they're not fatal, we run into the issue of potential damage to the spine. Injuries of the head are classified as either open or closed for the same reasons. A closed head injury, we're worried about bleeding inside the head. And an open head injury, we're worried about bleeding, profuse bleeding, and then potentially fractures of the skull and exposed brain matter. Signs and symptoms of head injuries we discussed, and then in general we want to stabilize these injuries, support the head, neck, and spine, and supportive care for airway bleeding and circulation. Airway obstruction is the primary danger in severe facial injuries. We want to be sure that we have suction available. If you suspect a spine injury, don't move the patient during examination. Consider the application of a cervical spinal immobilization collar. The most common chest injuries are rib fractures, flail, chest, and penetrating wounds, and we discussed how to treat those. So let's do a quick review, and then I'll put you on break. So the musculoskeletal system refers to involuntary muscles of the nervous system, connective tissue that supports the skeleton, bones and voluntary muscles of the body, or the nervous system's control over the muscles. What do we think? I see a lot of C's. Does anyone disagree with C? All right, and the answer is C, bones and voluntary muscles. When examining an injured extremity, you should be sure to manipulate it in different directions to determine where the fractures might exist. Keep it elevated at all times. Splint it to reduce movement before conducting any assessments, or squeeze the entire limb starting from the top in a systematic, firm manner. Couple C's, couple D's. Do we want to jump straight to splinting before we start doing an assessment?
No.
Does anyone remember what we called that? What is it?
Jumping the gun. Jumping the gun.
Jumping the gun. What do we call it when we jump straight to splinting our patient before we check for A, B's, and C's?
Something about death or something?
Yeah, splinting the patient to death.
Yeah.
Don't do that. So the answer is, of course, D. And then finally, facial injuries should be identified and treated as soon as possible because bleeding is more obvious on the face. Patients are always concerned about their faces. Swelling may mask hidden injuries or the risk of airway problems. I see a bunch of D's in there. And you are correct. The answer is D. All right, so let's take a quick break. And then we will get into basically all of medicine. No biggie. So take a 10-minute break, come back 10 after 8. Okay. So we're going to be covering pretty much all of medicine. And again, this is something that takes up, probably 100 hours worth of time in an EMT curriculum and 1,000 hours in a paramedic curriculum and years in a physician's curriculum. So, and we're just going to go over it in the next hour and a half. So there's so much more to learn, and there's so much continuing education that you can do to make sure that all of these various disorders are something that you're familiar with, right? And again, we don't expect at the EMR level that we are going to be able to diagnose a lot of these things, right? Where our goal is primarily to recognize life threats and apply stabilizing interventions. But I think a familiarity with a lot of these subjects will pay you dividends the more you get out there on the ambulance and start running calls. So what we're going to focus on tonight is some common medical conditions. So we're going to spend some time on the heart, talking about angina, heart attacks. We're going to go a little bit into congestive heart failure. We're going to talk about, along that veins, sources of difficulty breathing, also known as dyspnea, including asthma. We're going to talk a little bit about stroke and stroke assessments. We're going to talk a little bit about diabetes and hypoglycemia. And then we're going to dig into the wonderful and exciting world of abdominal pain. And I think I cannot overemphasize it. It bears repeating. Your systematic approach to assessment is what's going to help you figure out what's going on, right? Because there's nothing worse than having a sick person in front of you and just not knowing what to do. And so your systematic assessment is the thing that you have to do. This is what's going to help you take care of the patient. So treating patients with medical conditions can be very challenging, but EMRs can prepare to treat medical patients by studying signs, symptoms, and treatments of each of these conditions that we'll talk about. Using a systematic approach to patient assessment will ensure that all life-threatening conditions are found and treated quickly. And then your thorough secondary assessment and patient history will uncover the clues that you need to determine what actually is going on with the patient. So the first thing we want to do is on our way to the call, we're going to review the dispatch information to help us figure out what problems are more likely. Carefully assess the scene to identify pertinent safety issues for you, your crew, and your patient. And then as you perform the primary assessment, first try to form that impression of what the patient's problem is. Why are you there? What did they call 911 for? Then determine the patient's responsiveness, introduce yourself, check the patient's ABCs, and acknowledge the patient's chief complaint. Ask them, why did you call 911 tonight? What seems to be the matter? And in their own words. What's that?
In their own words. What's that?
That was a trip. Did you have a question?
Max, I think they were having issues logging in, and when you first log in, it actually opens up the microphone.
Oh, I thought I turned that off. Okay. Alrighty. Yep. Okay. So, generally speaking, for medical complaints, it's a good idea to obtain your medical history before you start doing your secondary patient assessment. And this is the exact opposite as trauma because, again, the history is what's going to give you the clues about a medical complaint. And then you'll do a focused physical assessment based on what their complaint is. Because it doesn't make a whole lot of sense if someone's complaining of abdominal pain to go head to toe and, palpate all of their bones and things like that. That's just not their problem, right? Whereas in a trauma patient, it does make sense to do that first because their history of high blood pressure has absolutely no bearing on your trauma assessment. So again, for medical patients, it makes sense to do a sample history before you dig into a head-to-toe physical exam or a focused physical exam, depending on their complaint. Also, your quantitative vital signs, so your heart rate, respiratory rate, and blood pressure, those are going to be really important to figuring out what's going on here. And to recap sample, remember that sample stands for signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and then events associated with or leading up to the injury or illness. And then, in general, as you're speaking with the patient, remember to reassure them and not use overly medical jargon and to let them know that you're there to help. So general medical conditions may have different causes yet result in similar signs and symptoms. There's a lot of overlapping signs and symptoms. So learn to recognize signs and symptoms as well as general treatment guidelines so that you can provide immediate care. Initial treatment can stabilize the patient until other EMS or hospital personnel can take over for you. So the first thing we're going to talk about is altered mental status. And this is something that we're generally trying to get in our general impression, part of our scene size up, as we look for level of consciousness using the AVPU scale. So altered mental status. A sudden or gradual decrease in a patient's level of responsiveness is pretty concerning. And so obviously to assess this, we use the AVPU scale. So A is awake and alert. So when we arrive, an alert patient will answer simple questions accurately and appropriately. They'll look at you and follow you with their eyes. They'll be awake and alert. Below that, if someone is responsive to verbal stimuli, this means a patient will either react to loud noises. Maybe when you call their name, they'll open their eyes, but they're not really, again, awake and alert. They're not really with it. Below that, we have responsiveness to pain. So this is a person who is responsible to painful stimuli, and they'll either move or they'll cry out, but they won't become fully awake. They may not open their eyes or anything like that. And again, when we're checking for painful stimuli, just simple maneuvers like the sternal rub are enough to elicit some kind of pain response. We're not trying to make our patients suffer. We're just trying to check if they're responsive or not. And then finally, if they don't react to anything, they are unresponsive. When assessing the patient's mental status, consider two things. First, the patient's initial level of consciousness, and then, as you're working with them, any change in that level of consciousness over the period of time that you're with them. A lot of different conditions will cause an altered level of consciousness. And so we've already talked about a lot of these: head injury, shock, decreased level of oxygen to the brain. But we're going to get into some of them tonight, which is like stroke, problems with the heart, or infection. And then sometimes a psychiatric condition will be the cause of an altered level of consciousness. And we're not going to go really deep into psychiatric issues, but it is a fascinating and increasingly relevant field for EMS providers. So definitely a subject for continuing education. If you can't determine what's causing the patient's altered level of consciousness, you can help them by treating the symptoms of the problem. Remember, everything goes back to ABCs. So we want to maintain their ABCs. We want to maintain their normal body temperature by keeping them warm. We want to make sure that no additional harm comes to the patient, either from themselves, from the environment, or from us. If the patient is unconscious and hasn't sustained any trauma, we can place them in the recovery position or use an airway adjunct to help maintain an open airway. Make sure that if you insert something into their mouth, you're prepared to suction, because there's a chance that the patient may vomit or not be able to handle the secretions accumulating in their airway, which would be like drool or something like that. Seizures are caused by sudden episodes of uncontrolled electrical impulses in the brain. Sometimes there are other causes of seizures, but generalized seizures produce these shaking movements and involve the entire body. Seizures can last maybe 1 to 2 minutes, although sometimes they can continue for more than 2, 5, maybe even 10 minutes. Patients are usually unconscious during these generalized seizures and don't generally remember the seizures afterwards. Although the seizures themselves are rarely life-threatening, the problem is they will stop breathing during the seizure, and they may injure themselves during the seizure. And so we're really concerned about traumatic harm to their body, and then also hypoxia from not breathing. One of the causes of seizures can be a high fever, especially in children. These seizures are called febrile seizures. They're pretty common in infants and young children, and then they become less common with adults. If an adult has a seizure because of fever, that fever is life-threatening life-threateningly high, whereas a child can fully recover from a high fever that caused a seizure. Some seizures result in only a brief lapse of consciousness. These seizures are called absence seizures, and they manifest in a variety of different ways. Patients may blink their eyes, stare vacantly, jerk one part of their body, lick their lips, or repeat a word over and over again. These are, again, generally not life-threatening, but if they happen, you're primarily concerned with A, B, and C. So you have to maintain and monitor ABCs and arrange transport to an appropriate medical facility if they agree to go. A lot of people with seizure conditions know they have seizure conditions and take medicine for seizure conditions. And so if there's any change in the patient's medicine or a breakthrough seizure, if they don't have enough medicine, this is going to be something that family, friends, or possibly even the seizure patient will be able to tell you once they come out of the fogginess of having a seizure. And so Bernard asks, what temp will a child start having a seizure? It's generally temperatures above 104 degrees, although it really depends on the person. And so while a temperature of 104 degrees in an adult would be heat stroke temperature and is a life-threatening emergency, kids are a little bit more resilient and they'll normally work their way through those episodes just fine. So again, here are some things that can cause seizures. Hypoxia, one of the last things that your brain will do before it runs out of oxygen is just give a little shake and a little wiggle, and then you'll pass out. We talked about fever, infection that causes fever. Poisonings can sometimes cause seizures, mostly as a result of hypoxia. Overdoses, again, as a result of hypoxia. Brain tumor or certain infections of the brain will cause direct activation of electrical signals. Diabetic emergencies, as your blood sugar gets really, really low. Again, one of the last things that your body will do, that your brain will do before it runs out of sugar, is give a little wiggle, give a little shake. And then as a complication of pregnancy, a condition called preeclampsia, or rather eclampsia, which is not something we're going to dig into very deeply. And so Nick is asking, do narcotics have a big role in seizing? And so opioid narcotics don't do anything for seizures. If you overdose on an opioid, you'll run out of oxygen. And again, your brain is running out of the thing that it needs the most. Oxygen and sugar is what we run on. If either of those things disappear, the last thing the brain is going to do before it turns out the lights is give you just a little wiggle and a little shake. This is not a full-on seizure. They actually just look like little shudders before you pass out. Whereas a general tonic-clonic seizure, the full-on kicking chicken flopping on the ground, the types of seizures that are really going to cause injury and broken bones, those are caused by electrical activity in the brain, most commonly. That said, there are other types of drugs that we give to people with seizures that can have a narcotic effect, and these are in the class of benzodiazepine. You don't have to remember that, but drugs like Versed and Valium and things like that. But again, only a paramedic would be able to administer those. However, sometimes patients will have these drugs to take at home, and if you're an EMT or higher level, you can help administer these drugs. But at the EMR level, we are not going to do any of that. All right, so treatment. Generally speaking, and this is a good thing in most cases, seizures will be over by the time you reach the scene, right? These seizures tend to last only a couple minutes, and it usually takes us a lot longer than that, especially in rural areas, to get on scene. If it hasn't ended, that is very concerning, and our treatment should focus on protecting the patient from further injury. Now, when we protect the patient from further injury, we should also consider our own safety. So this patient has absolutely no control over the spastic motions of their body, and their muscles are contracting with a great deal of force. And so if you try to like jump on the patient and hold them down, it could be that you end up getting your own collarbone broken by the back of the patient's head or something like that. So the best thing you can do is move furniture away from the patient, try to pad underneath them if at all possible, and then allow the patient to finish the seizure before you jump in and start maintaining airway, breathing, and circulation. If the patient doesn't resume breathing after a seizure, or if the seizure is prolonged, you can begin mouth-to-mask or mouth-to-mouth breathing. Sometimes the patient's jaw will be clenched shut, so it'll be difficult to get a seal with the bag valve mask, and in which case you can administer supplemental oxygen either by blow-by or whatever method that you can manage given the resources that you have. So some specific medical conditions. We're going to cover a lot of different information, and it would definitely, for the short term, it will definitely help you to go through your book to memorize vocabulary terms and to just be generally familiar with the overview of each of these conditions, right? You're going to be asked to recognize these conditions by their signature signs and symptoms, and there's a lot more learning that can be done, but we're not going to go real deep into any of these things. So we'll start off with heart conditions. So as we talked about before, the heart muscle is pretty unique. It is constantly contracting and relaxing, From around 6 to 8 weeks of gestation all the way until you die. It is constantly working, and that's extraordinary. But as a result, it requires a constant supply of oxygen. Otherwise, it will begin to die very quickly. It's very sensitive to disruptions in oxygen. And the heart receives this oxygen through a complex system of coronary arteries. And the coronary arteries are the heart arteries that are on the outside of the heart that feed the muscle tissue. And so if you have coronary artery disease, they may narrow as a result of something called atherosclerosis or arteriosclerosis. Those are two different things, but they are very related. Now, this is a disease that causes layers of fat to coat the inside walls of arteries, and it coats all of the walls of all of the arteries of your body. So it's not just the arteries inside your heart, it's the arteries everywhere. So why do we care about the heart? Well, again, because if the heart's arteries close off, we will know immediately. Whereas if the arteries of another organ close off, we will have organ damage and it will manifest in other ways, right? So progressive arterial sclerosis can cause what's called angina pectoris, which we'll talk about next, a heart attack, or even cardiac arrest. And a heart attack and cardiac arrest are two different things, and we'll talk about that as well. So let's talk about angina pectoris. So this is chest pain caused by an inadequate flow of blood and oxygen to the heart muscle. Angina is often described as pressure or a heaviness over the chest. Angina attacks are usually brought on by exertion, sometimes emotion, sometimes eating. The classic angina is, mid-60s old white man, doing something around the house, mowing the front yard, working in the shop or something like that. And he all of a sudden starts developing crushing chest pain. He goes inside, he sits down, 15 or 20 minutes later, the pain goes away, right? And so when the heart is working hard, when we're pushing that lawnmower, when we're moving heavy objects, the heart has an increased oxygen demand. And through narrowed blood vessels, it's like breathing through a drinking straw. You're just not going to get enough oxygen. And so the heart complains. It manifests in pain. But then you sit down, you relax, the demand on the heart goes down, and the pain goes away. And this is called stable angina. Crushing pain may be felt in the chest. It may radiate to one or both arms. It can go up the neck into the jaw or any combination of these sites. And it does that because it follows sort of the nerve pathways around the body. So patients can complain of crushing chest pain, pain shooting down their arm, pain shooting up into their face, pain in the center of their back, or a lot of different other symptoms. One of the things that patients will often describe is a sense of impending doom, a sense that they're going to die. And it's a sort of indescribable feeling, but it seems to be pretty common throughout patients, that sense that this is the end. Now, there is treatment for this. One of the first things we want to ask our patient during our medical assessment is whether the patient is already being treated or is already diagnosed with a heart condition and has a medicine called nitroglycerin. Nitroglycerin is a fast-acting medication that causes the blood vessels throughout the body to get bigger. And if a narrowed blood vessel gets bigger, the narrowing goes away. Now, this is only temporary, so it only lasts a few minutes. But if a patient has been prescribed nitroglycerin, we can assist this patient in either taking one of these pills or administering the spray underneath the tongue. If the pain hasn't lessened in about 5 minutes, we can give a second dose and assume the patient is having a heart attack, and then get the cavalry on their way, transport this patient immediately. And so here's a picture of the bottle that it comes in. It's tinted brown because it's sensitive to light. We'll also see patients sometimes carry a vial that looks like this, either as a necklace or on a keychain, and you can fit several nitroglycerin pills in this container. And so again, to administer the nitroglycerin, we put it underneath the tongue and allow it to dissolve. And the patient should describe it as sort of a fizzy feeling. So again, we can help this patient take this drug if they are prescribed the drug for an existing heart condition. If they're not, then we can't give nitroglycerin. All right, so the worst case scenario is that their angina escalates to a heart attack. A heart attack is also known as a myocardial infarction. And if you break that down, myo is muscle, cardio refers to the heart, so myocardial. And then infarction is what happens when you block the flow of oxygen to an organ and the tissue starts dying. We call it an infarct. That's just what that means. The tissue is dying. And so a myocardial infarction is when the muscle of the heart is dying because it doesn't get enough oxygen. And this results when one or more of the coronary arteries is completely blocked. So it goes from narrowed to blocked. Two of the primary causes of coronary artery blockage are severe atherosclerosis. So again, this is a buildup of fat, or a blood clot from somewhere else in the circulatory system that breaks free and becomes lodged in the artery, right? And so here we see in the image, this is a fat clogged artery from a lifetime of decisions. And now we also have a clot that's sort of wedged in there, and this person is got a 1-2 punch that could potentially kill them. And so what are some signs and symptoms? Well, the patient's going to suffer an immediate and severe crushing chest pain, right? These patients usually grab their chest, put their hand right over their heart, and bend over or topple over. The pain may radiate from the chest to the left arm or up into the jaw. Again, same types of pain. They usually become short of breath almost immediately as their heart weakens and starts pumping ineffectively. They'll begin sweating. They'll feel nauseous and may vomit. They're going into effectively cardiogenic shock. And if the blocked area is critical, or if it's a large vessel, the heart may suddenly stop completely. And so that would be, it would go straight from a heart attack into a cardiac arrest. So complete cessation of the heartbeat is called cardiac arrest. You can have a heart attack and not need CPR, but if you're going into cardiac arrest, the cardiac function has arrested, which means it has stopped. And so CPR is the first emergency treatment for cardiac arrest. We want to summon additional help. We want to check for responsiveness, check for breathing, circulation, and initiate chest compressions if we find that they have no heartbeat. If they are still conscious, if they're still able to talk with you, if they're still suffering from cardiac pain, we're obviously not going to do CPR until they go into cardiac arrest. So if they're having a heart attack and they're not in cardiac arrest, we want to sit them down. We want to limit their movement and limit the demand on their heart. If they have aspirin, or if you have aspirin, you can administer 325 milligrams of adult aspirin, or we can give 2 to 4 baby aspirin, the chewable 81 milligram aspirin, right? So this is something that we can carry in our kit and we can give to these patients, right? One of the only medicines besides oxygen that we can just give to someone if we have it. So again, we're either giving them a 325 milligram aspirin, or we're giving them 2 to 4 81 milligram chewable aspirins. If we have oxygen, we want to administer it because, again, the problem is that their heart isn't getting enough oxygen. So if we can maximize the amount of oxygen in the blood, that will help them. And then be prepared to administer high-quality, high-performance cardiopulmonary resuscitation. If you have an AED available, you want to get it ready because we know that early defibrillation improves survival. And your primary role is to provide emotional support and arrange for prompt transportation. Because there's not a whole lot we're going to do medically for this patient until they go into cardiac arrest. All right, so let's talk about congestive heart failure. And this is probably something that you've heard of. This affects, elderly family members. But congestive heart failure is caused by a failure of the heart to pump blood adequately. So either pump the blood up into the lungs or to pump the blood away from the heart to the rest of the body. If one side of the heart becomes weak and can't pump as well as the other side, then the circulatory system becomes unbalanced and results in what we call circulatory congestion, which means that the blood pools in places. In CHF, the failure is in the heart muscle, but the congestion is in other blood vessels. So here we see on the screen that a congestion in the heart can cause blood to back up in the lungs. And if it does that, we see that fluid starts to enter the air space. And we can hear that in someone with CHF if they have rattling respirations, if it sounds like a pool filter when they breathe, like their lungs are filling up with liquid, that is from a type of congestive heart failure. The other thing that we will tend to see is pooling of fluid elsewhere in the body, especially in the lower limbs. So we'll see swollen legs and swollen ankles. We'll see enlarged veins. And so all of this are examples of signs and symptoms that we'd see with congestive heart failure. It's a heart problem, but it can lead to breathing difficulty. So if you encounter a patient with CHF, as soon as you figure out that that's what's the problem is, you want to place the patient in a sitting position with the legs down. If you lay this patient flat, then all of that fluid is going to rush up into their lungs and they will drown. So this type of patient needs to be sitting bolt upright. And a lot of times they won't even let you lay them down. They will refuse to lay down because they can't breathe. We also want to administer oxygen in large quantities at a high flow rate. So this is going to be a non-rebreather mask at 15 or more liters per minute. We also want to get more help on the way because at the EMT, advanced EMT, and paramedic level, there are some medicines that can be administered that will help this patient and help their condition from getting worse. So speaking of breathing difficulty, let's talk about dyspnea. So whenever you see DYS attached to a word, that means trouble or problem. And then PNEA, pronounced pnea, is referring to breathing. So dyspnea is difficulty breathing. That's all that means. So we will call this shortness of breath or difficulty breathing. It's usually associated with some sort of serious heart or lung disease. So heart-related causes include, again, angina pectoris, a heart attack, and CHF. But some of the pulmonary diseases, such as chronic obstructive pulmonary disease or COPD, emphysema, chronic bronchitis, which are the components of COPD, pneumonia, and asthma can cause dyspnea. So COPD and emphysema are caused by damage to the small air sacs in the bottom of the lungs. These are called alveoli. And chronic bronchitis is caused by an inflammation of the airway in the lungs. And so we see this a lot in people who have a lifetime exposure to polluted air, for example. This includes people who smoke cigarettes, people who vape or are generally inhaling particulates in their lungs. We see this sort of lung damage. Pneumonia is caused by an infection in the lungs, and pneumonia can result in either a buildup of pus or fluid or inflammation deep in the lungs, and this is a treatable medical condition, but not treatable by us. And then asthma is a condition caused by the clamping down or spasm of the airway passages inside the lungs. So not the upper airway passages like a choking, but the lower airway passages because of smooth muscle. And so we're not going to spend a whole lot of time trying to determine the specific cause of dyspnea, but we need to focus on treating the symptoms. So in general, you want to check the patient's airway to confirm that it's not obstructed, that they're not choking on something. We want to check the rate and depth of the patient's breathing. So again, if their rate is slow or their depth is shallow, we may have to assist with ventilations. Or if their rate is adequate but the depth is poor, or the rate is high and the depth is poor, then we may have to assist with ventilation through a bag valve mask. And in any case, we may have to apply high flow oxygen. We want to be prepared to assist with some sort of rescue breathing. Place the patient in a comfortable position. Again, the most comfortable position may not be laying on their back. We want to provide them with reassurance because these patients are often anxious. Loosen any tight clothing if applicable. And then again, administer oxygen. So speaking more to asthma. Asthma is a super common condition, and asthma is exacerbated by a lot of environmental situations. So if you live in the bad part of a city next to a factory, or you live next to a highway, or you're really reactive to pollen in the summer, then asthma can be triggered by a lot of these environmental problems. But it can also be triggered by exertion. Like high school sports. It can be triggered by severe emotional distress, and then also respiratory infections. And so one of the things we saw, one of the comorbidities for COVID-19 was if you had asthma, COVID was going to hit you especially hard because not only were your lung tissues going to get destroyed, but your lungs were just going to close off and prevent you from breathing. So insult to injury there. So what causes asthma? Well, it's caused by both a clamping down and an inflammation of the airway passages. So we see that the smooth muscle around the airway passages, the muscle that you can't control, gets tighter in response to whatever is causing the asthma attack. And then your airway produces a lot of extra mucus, a lot of extra fluid. And the mucus is meant to capture pollutants that enter the airway, but in this case, this is an overreaction, and the result is that you start suffocating to death. So what can we do about it? Well, this kills a lot of people every year, and that number up there on the screen, 3,600 people, that's actually gone up significantly. And it will continue to go up as we see things like climate collapse and global temperatures start to rise. Because air quality will continue to decrease. And so these patients experiencing an asthma attack will have a lot of difficulty exhaling through their partially obstructed airway passages. And so this is going to cause a sound, and we call that sound wheezing. So when you hear someone wheezing, it's because the passages inside their chest are closing off. Now, a lot of these patients will have taken medication before your arrival, and then sometimes the medication isn't going to be enough. Patients can die during asthma attacks. And so you want to follow the treatment steps for dyspnea. Instruct the patient to perform pursed lip breathing. This is a way to open up these airway passages by increasing the internal pressures inside the lungs. And then if advanced life support is not available, we need to get these patients to the hospital immediately. And so here on the screen, I have a metered dose inhaler. This is an albuterol inhaler. And so again, hopefully the patient will have taken their inhaler soon. It's better to take these sooner rather than later. It's called a rescue inhaler, but it's not going to rescue you after a certain point. And so increasingly we see asthma action plans as patient education. So an asthma action plan may be something you see posted on the refrigerator as you're looking around the house. So that's asthma. Let's move on to stroke. So stroke is a big problem in America. It's one of the medical conditions that was added on to the EMS curriculum really early on as we were developing the trade of EMS. And so it's one of the leading causes of brain injury and disability in adults. Most strokes occur when a blood clot blocks the supply of blood leading to a part of the brain. And the signs and symptoms of this are going to vary wildly depending on which part of the brain is affected. So it could be something as simple as a headache, or they could have numbness or paralysis on one side of the body or the face, dizziness, confusion, and a lot of other symptoms. And so one of the classic signs is that facial droop, right? And so here we see a relatively young and healthy person who all of a sudden got a blood clot, which if you are a young woman who smokes and you're also on birth control and you have certain genetic predispositions to clotting, this is certainly something that could happen. And so this person, we can see that she is suffering from that facial paralysis and weakness. And so one side of her face is drooping down. And try as hard as she might to smile, we see that she has an asymmetrical face. And so that's a really strong indicator that, that there's a stroke or something like a stroke going on. And so we have a scale that we can use on scene and in the ambulance to assess this. And this is called the Cincinnati Pre-Hospital Stroke Scale. And this is an easy to administer and pretty accurate tool that you can use to determine whether a patient may be experiencing a major stroke. And this requires no equipment and only has 3 steps. So the first step is assessment of the facial muscles by having the patient smile. And again, you're going to have them give you a big toothy grin, right? Because you're not trying to make them feel better. You're looking at how strong their face muscles are and how well they activate. The next thing you're going to do is test for what's called pronator arm drift, right? So arm drift. And so we're going to have them close their eyes and hold their arms straight out in front of their body like they're holding 2 bowls of soup, right? And it's really important that they have their arms what's called pronated, or with the palms facing up, right? This activates a bunch of muscles that are not as strong as the normal muscles you use every day. And so what this is going to do is if there's any weakness in one side of the body or the other, you're going to see that arm slowly drift away. And it's important that they close their eyes, because if they have their eyes open, they can try to compensate with other muscles in their arms, trying to keep that arm up. So again, have them close their eyes and then hold their arms straight out and give it a good 10 count. And then finally, you're going to assess their speech. And this is assessing certain nerves and muscles in their face and tongue. And you want to ask them to repeat a word or a phrase like, "You can't teach an old dog new tricks." And what you're expecting is that if they have any sort of numbness or thickness in their tongue, weakness in their tongue, that they're going to start slurring. "You can't teach an old dog new tricks." Something like that. So if you figure this out, if they're having a stroke, again, your priority is ABC. You want to maintain that open airway, especially if they're having weakness in the face and the jaw, right? Because they may not be able to maintain their own airway. You want to administer oxygen if it is necessary. You want, you want to administer oxygen, period, because the problem is a portion of their brain is not getting enough oxygen. So we want to load every red blood cell with as much oxygen as possible in case there's some sort of collateral circulation up there. So put them on high flow oxygen. And if the patient is having a seizure, try to prevent further injury. And as always, be prepared to administer rescue breathing and other emergency interventions. Again, if we don't suspect any other trauma, we can place them in the recovery position until we can get them strapped into an ambulance. We can give emotional support by touching the patient. Some stroke patients can be treated with special drugs if they get to the hospital soon enough, and the window is within a couple hours of the onset of the symptoms. And so again, one of the questions that we're going to ask is, when is the last time that they were well? And oftentimes the patient can't answer this themselves, and it's the family answering the question. But if you ask the question, when's the last time you saw grandma, normal, and the answer was last night before she went to bed, chances are we're not going to be able to do a lot for her even if we get her to the hospital. So it's important to ask these questions because it determines what kinds of treatment will be administered. All right, so let's move on to diabetes. Actually, let's pause there for a second. Any questions on hearts, lungs, or brains? You have a question, Andrew?
Yeah, I just wanted to wait for a second. As far as these different topics and whatnot, do you have an idea of like how in depth they're going to try to be on as far as testing goes?
This in depth. This is as in depth as you need to go.
Okay.
There is a lot more to learn. Not just more depth, but more breadth, right? And so at the EMR level, we focus on simple depth and simple breadth of information. Whereas if you go up into the EMT or higher level, not only do you learn more conditions, but you learn more about each condition. But that's not what our job is as an EMR. As EMRs, our jobs are to find those life-threatening injuries and stabilize them while we wait for the EMTs and advanced EMTs to show up. And so you're not expected to understand a lot about these conditions, but you're expected to know when to apply those life-saving interventions like oxygen, opening an airway, providing rescue breathing, things like that. So as long as your knowledge drives you towards those life-saving interventions, that's what you need to know.
Will do.
All right, so let's dig into diabetes. Actually, let's not do that. Let's take a break. It is now 8:58. So why don't we come back in about 10 minutes, and we'll pick up with diabetes, and then hopefully we'll finish off the night with just a taste of toxicology. So take 10. All right, we're going to pick back up with diabetes. So diabetes is caused by the body's inability to process and use glucose, which is sugar, which is carried by the bloodstream to the body's cells. The body cells need both oxygen and glucose in order to make energy, in order to survive. And so the body produces a hormone called insulin that enables the glucose to be carried by the blood and move into the cell where it is broken down and used as fuel. If the body doesn't produce enough insulin, or if the insulin that it produces is the wrong kind, then the cells become starved for glucose and problems result. So many diabetics have to take supplemental insulin injections, but there are types of diabetes that can be managed through through diet and other modification. So Morgan asks, is this for type 1 and type 2? And so we don't get into type 1 and type 2 at the EMR level. At the EMT level, we would, but we don't differentiate. We just say bad sugar problem. So diabetes is a serious medical condition. Two specific medical conditions can occur with diabetes, right? So diabetes itself, it's sort of a lifelong problem with a lot of issues that come along with it. But the emergency problems come in one of two flavors: hyperglycemia, which is a blood sugar that's too high, and hypoglycemia, a blood sugar that's too low. So remember hyper and hypo, high and low. So let's talk about hypoglycemia first. This is the more noticeable of the two. So hypoglycemia occurs when the body hypoglycemia occurs when there's not enough glucose in the blood in order to feed the cells, right? So the body has enough insulin, has enough of the right kind of insulin, but there's not enough blood glucose. And this comes from an inability of the body to maintain its own stores and levels of sugar. An older term for hypoglycemia that you may hear older folks refer to is insulin shock, although that's sort of an inaccurate term. Do you have a question? I can't see when people raise their hands. Leo? Nope. Okay. So some signs and symptoms of hypoglycemia is we're going to see this person with pale, sweaty, cool skin, sort of like they're going into shock. We may also feel a rapid and weak pulse, dizzy, headache, confusion, or unconsciousness. So a lot of times these patients are described as looking and acting intoxicated or drunk, right? And this, again, it comes from the brain being starved of that sugar, one of the two things that it needs to survive. And as a result, they slowly descend into this altered mental status. These patients sometimes also report being hungry, and this is sort of a reaction from the body when it's starved for energy. It wants to consume energy. So we want to suspect low blood sugar if the patient has a history of diabetes or is wearing a medical emergency information bracelet or some kind of extra information card. If hypoglycemia is not diagnosed and corrected by the administration of glucose in some form, then the patient may die. Running out of sugar is a big problem. So again, a person experiencing hypoglycemia may act and appear drunk, but try to get the answers to the following questions. Are you a diabetic? Yes or no? Did you take insulin today? Yes or no? Have you eaten today? Those are important components of your medical assessment, right? So are you diagnosed with this problem? If you were prescribed insulin, did you take it? And if you took insulin and then didn't eat, well, there's your problem. Or if you didn't take insulin, but you haven't eaten today, that may also be a problem. So if the patient is able to swallow, we can attempt to get them to eat or drink something sweet. Now, all ambulances and a lot of first aid kits will come with this oral glucose gel solution, and there's 15 grams of sugar in each one of these. Still not as much sugar as a Monster Energy drink, but enough sugar to sort of get them going in the right direction. And if you ever were to taste these, they taste exactly like cake frosting. They're really, really super sweet. And so if the patient is unconscious, then we can't administer anything by mouth, right? If we put something in the patient's airway, then we've caused an airway obstruction, period. So we don't administer fluids by mouth. We don't administer these oral gels by mouth because the patient will choke on them, and then we have hypoglycemia plus an airway obstruction. However, if the patient is awake, then you as an EMR can administer a tube of oral glucose, either the gel or the tablets, or something else that can be placed inside the patient's cheek. Now, what I've seen is the patient who is hypoglycemic and, perhaps has been in this condition more than once will take this right out of your hand and suck the whole thing down, right? They know what they need. And so if that is the case, if they are able to, maintain their airway and they're able to maintain motor control, then let them have it, right? Because they need sugar. All right, so diabetic coma. So this is another sort of colloquialism. This is what we refer to as hyperglycemia. And so if we look at the symptoms here, right? So a history of diabetes. This person's skin signs are slightly different, so warm, dry skin, right? But they may still be sweaty, who knows? Rapid pulse, again, same as hypoglycemia. Deep, rapid breathing in some cases, not always. Fruity odor on the patient's breath, again, only in some cases. Weakness, nausea, vomiting, increased hunger, thirst, urination. So you can see there's a lot of overlap between too high and too low, right? And so it's pretty common to mistake one for the other. But which do you think is worse? Which do you think is going to kill the patient?
Hyperglycemia.
Hyper or hypo?
Hyper.
I say hypo.
So hypo?
Yeah, I do.
Right, because what? You say hyper? All right, so what is going to hurt the patient in hypoglycemia?
Well, your body needs sugar to survive, obviously, along with oxygen.
Yep.
So if you run out of sugar, you run into no sugar, obviously. So
Right, cell death. You literally don't have the chemical components needed to make the energy that runs the machinery of life. So then, on the other hand, what will hurt you with hyperglycemia?
you're getting too much of it.
Will that hurt you, though? In sort of an acute, immediate, life-threatening sense.
Not necessarily, no.
Yeah, not on the same time scale, right? So
It takes longer.
hyperglycemia is still a damaging condition, and if it gets high enough, it certainly can cause things that will kill you, right? It can shut down your kidneys. It can cause other sorts of organ damage. So it certainly is a very serious condition. But out of the two, hypoglycemia will kill you before you get to the hospital, right? And so misdiagnosis is common between hyper and hypoglycemia, but when in doubt, err on the side of hypoglycemia, because let's face it, if your blood sugar is, way up in the, 6, 7, 800s, like super, super high above normal, 15 grams of glucose is like peeing in the ocean and expecting it to warm up. It's just not going to happen, right? Whereas 15 grams of glucose when their blood sugar is down like around 20 or 40 is going to save their life. And so we need to err on the side of caution, and the most conservative treatment is giving the sugar. So it doesn't matter if their blood sugar is too low or too high, we're going to give them sugar if we suspect that it's a diabetic-related crisis. Does that make sense?
Yeah, if I remembered my reading, I would have caught on to that.
Well, and so here we see the table directly from the text. And you see there is some differentiation. If you're really switched on and you're really paying attention, then the difference between pale, moist, cool skin and warm, dry skin. But again, not everyone is going to present with these classic symptoms. Not everyone with low blood sugar is going to have pale, moist, cool skin. And not everyone with really high blood sugar is going to have the warm, dry skin. And other than that, we have, changes in pulse, changes in level of consciousness, so we're really not going to be able to tell them. And the important thing is, do you have a diagnosis of diabetes? Do you take insulin? Have you eaten anything today, right? And through those questions, we can get a pretty good idea of what's going on and what we should do. So again, regardless of what's going on, we're going to administer something that contains sugar as long as they can maintain their own airway. And the patients who is experiencing the low blood sugar, the sugar may improve the patient's condition. If the patient is experiencing high blood sugar, the sugar is not going to raise glucose enough to do them any further harm. So in general, give conscious diabetic patients sugar by mouth. If the patient's unconscious, then we just need to take them to the hospital. All right. Now, finally, we're going to dig into abdominal pain. So,
I have a quick question.
yes, please.
So, about the tubes. So, last night at our meeting of everybody that's going to be doing the rescue here in Charlestown, there was a debate whether we could administer aspirin and as well as the glucose. And they were saying you can't administer anything. But in here, like me and Nick just heard you say that yes, we can give aspirin.
Mhm.
But for clarification, yes, we can do the glucose, or is that only if your station or wherever you are allows you to administer it?
All right, so before I answer this question, I am going to check my references because that is always a good idea. So let's do New Hampshire protocols.
If it makes you feel
version
better, mine told me I can't administrate oxygen, which seems crazy.
Well, let's see if it's detailed in the New Hampshire state protocols. And so, all right, so BVM, suctioning, oxygen, we can give ourselves auto injectors, we can give Narcan, we can do CPR and defibrillate, we can insert airways, we could do hot packs. Heck yeah. Wound care. All right, and then it doesn't get into drugs. So let's see if we can find the drugs.
I also have a question after this.
So, in the state of New Hampshire, their EMR is not mentioned anywhere in the drug reference. So, it doesn't say anything about EMR. So that could be taken either they just didn't cover it because we'd never expected EMRs to be a part of the EMS system. Or you could take it to mean that EMRs cannot give any of these drugs, to include Narcan, which we know is false, or epinephrine autoinjector, which we also know is false, right? So aspirin, oxygen, an EpiPen, oral glucose, Narcan. These are things that we are going to train you to do in this course. Whether your agency allows you to do that, I would say if you feel that you should be allowed to do it, then it's really up to your agency's medical director. Because ultimately, I don't get to say what you get to do. My job is to teach you according to the national standard curriculum, which I am doing. If your department is unsure how to utilize you as a trained, licensed, certified medical professional, then you need to go to the medical director that oversees your department, because every single provider that runs on an ambulance in this state is directly reporting to a physician medical director somewhere. Right? So figure out who that person is and then ask them, this is what I was trained to do. I'm familiar with the indications. Is this something that you're going to allow EMRs to do in this service? Does that successfully avoid answering the question?
Yes, thank you.
Best non-answer ever. All right, someone else had raised their hand.
Yeah, altered mental status on a hypoglycemic person. Is there anything of that point on?
What's your question? So yes, they will have altered mental status.
Okay. It can get, from past experiences, it can get pretty physical with that person.
I mean, that depends on the person. Like you can't say that every single person is going to fight you. But I mean, obviously that is a hazard with someone with altered mental status, regardless of the cause. And it really depends on the individual. Okay, so let's talk about the guts. So the abdomen is just a crazy place full of mystery and wonder and pain and suffering. And it's really one of the most complex organ systems to try to diagnose. And so let's dig into it. In the next 20 minutes, we'll cover everything you need to know about the abdomen. So the contents of the abdomen are divided into hollow and solid organ structures. Hollow structures are just tubes through which contents pass. So an example would be like your intestines. And solid structures produce stuff. So an example of that would be like your pancreas or your liver. The abdomen occupies a large part of the body, and abdominal pain is a common complaint. So as an EMR, you need to recognize that the patient has an abdominal problem, but you're not expected to determine what the cause of the abdominal problem is. So the first thing we'll talk about is what's called the acute abdomen. An acute abdomen is caused by irritation of the abdominal wall. This irritation may be the result of an infection or may be caused by trauma or blood collecting in the abdominal cavity. And pain can be referred along those nerve pathways to other parts of the body. So they may have abdominal pain that feels like shoulder pain to them. It's crazy. So when you palpate the abdomen, it may feel really hard and rigid. And these patients may have nausea, vomiting, fever, diarrhea, pain, all sorts of stuff going on. Some patients with abdominal pain will vomit blood because they're bleeding from the esophagus or stomach. If the bleeding is in the stomach or above, they will vomit. And if they vomit dark digested blood, it's from the stomach. If they vomit bright red blood, it's from above the stomach, so the esophagus. Likewise, bleeding from the lower intestine, if they poop blood, it is from below the stomach. If they poop black tarry blood, it's been digested. And if they poop bright red blood, it's probably from hemorrhoids or something like that. Very rarely will someone produce a great quantity of bright red blood from their rectum. But when they do, it is a serious concern. So in any case, bleeding patients need to be treated for shock. If patient has abdominal pain, we want to just monitor vital signs every 5 minutes, treat for symptoms of shock, keep them comfortable, and get them to a hospital. One cause of acute abdominal pain is something called an abdominal aortic aneurysm, or a AAA. And this is relatively uncommon, but a AAA occurs when one or more layers of the aorta become weakened and separate from the other layers. So remember that arteries are muscular, and they have lots of layers of muscle going in different directions. And so sometimes those layers can get torn and blood can get in between the layers. And the more it gets torn, the more it's weakened. The more it can get torn, the more it's weakened. And then finally it explodes sometimes. And so this is more common in patients who have what's called comorbid conditions, or diseases that exacerbate or make things worse. So patients who have diabetes, patients who have high blood pressure, arterial sclerosis or atherosclerosis, heavy smokers, these are all at high risk for developing aneurysms or abdominal aortic aneurysms. So these patients may complain of pain, a tearing sensation in the abdomen. The pain may start to spread as the tear gets bigger. The these patients will just have a terrible time getting comfortable. They're going to be squirming all around on your cot, and really just having a terrible time. And then, of course, if the AAA ruptures, the patient will experience sudden severe pain and then profound shock, which is a very polite way of saying that they will begin to die very quickly. So what is the treatment? Well, we place the patient in a comfortable position, keep them warm, give them oxygen if need be, handle them very gently like a water balloon, because, I mean, they're basically a water balloon. And then get them to the hospital as quickly as possible. If you can get them to a center that specializes in cardiac repair and surgeries like that, then they'll have a better chance. All right, so let's talk about another organ that's hidden away in your abdomen, the kidneys. So people with certain types of kidney disease are unable to filter waste products from their bloodstream. Many patients with chronic renal or kidney failure undergo what's called hemodialysis. Hemo refers to blood, and dialyze is a filtering mechanism or filtering process. So hemodialysis is a filtering of the blood, and this is something they do 2 or 3 times a week. And so the patient's blood passes, it's drawn out of their body, it's run through a machine that filters out the waste products, and then the cleaned blood is then returned back to the patient. Now, in order to do this, they oftentimes have what's called a shunt implanted in their arm or their leg. The arm is more common than the leg. A shunt is anytime blood passes directly from an artery to a vein, right? Without going into the tissues of the body, without doing gas exchange, right? And we can surgically create a shunt by going in and connecting an artery to a vein. But the problem with that is when you connect a high pressure artery to a low pressure vein, the vein bulges out. And so here we can see that this is an arteriovenous fistula, which is a connection between the artery and the vein. And as a result, we see the vein is very large. And if you were to feel this, you would feel sort of the swirling, thrumming cavitation of blood going from the artery into the vein, right? If a patient has a shunt, you should not take the blood pressure in that arm, because you do not want to damage the surgical connection between these two things, or in some cases there's a device implanted in there and you don't want to damage the device. Patients who are being treated by dialysis may experience medical emergencies related to their dialysis treatment. It's an incredibly invasive procedure. You change someone's body chemistry very rapidly over the course of several hours, and so a lot of patients coming home from dialysis feel very sick for a while, and then as soon as they're starting to feel better, they have to go back to dialysis. So patients may experience a drop in their blood pressure because of changes in their body from the treatment. This decreased blood pressure can produce a shock-like state. Dialysis patients are also at risk for internal bleeding, especially if that fistula explodes. So hemodialysis patients may experience abnormal levels of electrolytes in their blood. These imbalances can cause cardiac arrhythmias that sometimes result in cardiac arrest. So treat the symptoms that present from this patient. And so a lot of times BLS providers, the EMTs, are put on what we call the renal roundup or hemodialysis transportation. They'll take people from home or from nursing facilities and take them to dialysis centers and back. And this is sort of looked down upon by a lot of EMS as sort of like, the crappy job. You're just sort of driving a van back and forth and nothing ever happens. Well, the more you understand about the complexity of the system, the more you realize that when things don't happen, it's because you got lucky, right? These patients are very ill and very fragile at baseline. And right after hemodialysis treatment, they are at their most fragile. And so a lot of things could happen. And so Morgan said some patients do an at-home dialysis. This is true. There are ways to do dialysis at home. they aren't as effective as going to a dialysis center. And so it doesn't filter out as much stuff as the hemodialysis centers do, but you have a greater quality of life because you can do it at home. So it's a trade-off. It's not as good, but you're not stuck in a dialysis center for hours at a time, spending a third or half of your life in a sterile room in a big chair hooked up to a machine.
And my thought on that was more, like you said, it's not as high quality of dialysis. So if you do come in with a patient complaining of, issues that may be with their kidney disease, that might be something to consider too if they are doing at-home dialysis, that, something could have gone wrong with that, or like you said, they just weren't cleaning everything out as well.
Right. Or, they say they do at-home dialysis, but the last time they did it was a couple weeks ago. Because compliance is an issue. Yeah, that's a good point. All right, so let's summarize here and then move on to toxicology. So general medical conditions have a lot of different causes, yet result in similar signs and symptoms. And so we, as EMRs, we're expected to recognize the signs and symptoms of general medical conditions and be knowledgeable about general treatment guidelines, so that we're able to provide immediate care for patients, even if we can't determine the exact cause of the problem, right? We're here to save lives, and we may not be able to diagnose what's going on, and that is okay. With a patient who has a general medical complaint, follow the systematic patient assessment sequence. It's usually best to collect a medical history using a sample format before you perform a physical examination, right? And that should make sense. It's more important to figure out sort of the medical causes of the problem than it is to poke and prod your medical patient. Altered mental status is a sudden or gradual decrease in level of responsiveness, and we use AVPU scale. We should be able to complete the patient assessment sequence to ensure scene safety, proper assessment. Initial treatment seeks to maintain the patient's ABCs and normal body temperature and to keep the patient from incurring any additional harm. If the patient's unconscious and has not sustained trauma, we can place them in the recovery position until we can get them in an ambulance. Seizures are caused by a lot of different things and can generally caused by uncontrolled electrical impulses in the brain. Usually the seizure will be over by the time you arrive, but if it hasn't ended, focus on protecting the patient from injury. Don't restrain the patient's movements because you yourself could get hurt. Once the seizure is stopped, then we can assess the patient, open their airway, make sure that they're breathing, and then get them to an appropriate medical facility. Some medical conditions typically encountered by the EMR include angina, heart attack, congestive heart failure. We talked a little bit about dyspnea, stroke, hypoglycemia, hyperglycemia, and abdominal pain. By learning the causes and knowing the signs and symptoms of these conditions, you may be able to provide more specific care to the patient. Although these conditions generally have to be diagnosed and treated by a physician, you can greatly improve the patient's chances of survival by taking some simple actions until more highly trained EMS personnel arrive on scene to assist you. So again, you don't have to diagnose these people, but you do have to identify the life-threatening conditions. And those are the things that are related to airway, breathing, and circulation. And then we can dig into the secondary assessment and find all of the other stuff that we could potentially make a little bit better. All right, so let's do a little bit of review. Signs and symptoms of a stroke include all of the following except numbness or paralysis, high fever, drooling, or unequal pupil size.
B.
Huh. Okay. B? Yeah, I think B is the least wrong answer. Yep, there we go. Which of the following actions would not be appropriate when managing a patient who is suffering from a heart attack? Place the patient in the most comfortable position, administer oxygen if it's available, be prepared to administer CPR, or move the patient as quickly as possible to the ambulance for transport. Which one would not be appropriate? We got a bunch of different answers here.
I read that. Sorry.
Which one would not be appropriate?
A.
All
I
right.
don't know.
So why do you think putting the patient in the most comfortable position is not appropriate?
Because if you're doing CPR, they're unconscious.
So why would we do CPR for someone having a heart attack?
Well, yeah, you're talking about cardiac arrest, heart attack. They just have a blockage.
Right. So they're awake, they're alert,
No.
they're in significant pain. So why would putting them in the most comfortable position not be appropriate?
Well, you don't want to really move them at all. So if you're moving them into a comfortable position, you may be moving them more than you should, which could then.
So if they're standing up, do you just want to leave them standing up? Or do you want to place them into a position where they are most at rest, that relieves the most amount of their cardiac burden, right? We don't want their heart pumping hard. We want them to rest.
I changed my mind, D.
Is there an E?
Is there an E? No, but there is one of these options that is totally not appropriate.
Oh yeah, move the patient as quickly as possible. So that wouldn't be. I mean, if you, I don't know.
Run, Forrest! I want you to run to the ambulance. And they get there, and then they collapse dead. And now you're doing CPR. Yes, absolutely. So placing the patient in the most comfortable position while they're having a heart attack, absolutely appropriate. Like, sit down, my dude. Like, lay back on the couch. The ambulance is going to get here. Don't even raise a finger. Like, let me get that nitro for you.
So Max, I think my thought process on A was, maybe they do go into cardiac arrest, and if you had them laying down at that point, I guess that's my thought process on that one. But
yeah, I mean, there's a lot of things that we could do in preparation for CPR. Like, we could get the AED out and put the pads on their chest. I mean, I think that would probably make their heart rate go even faster, and maybe they will go into cardiac arrest, right? Because you're going to scare the bejesus out of them, right? So it's knowing the time and the place. How long does it take you to move someone from a seated position down to the floor to start CPR?
no, probably seconds. Yeah.
Right. And so wouldn't it be better for them to be rested, comfortable, not anxious? Yeah, Catherine's going to hover over them with her hands like this, just like hover hands right over the chest, hover hands. He's going to code any second now. I know it.
No.
I can actually see that.
I was saying C because it would be kind of freaky to see somebody like being prepared for it. That's all I was saying.
So I think what C is saying, being prepared to administer CPR, that is like mentally and physically prepared. Like, have the AED with you. Make sure that you've discussed assigned roles and things like that. And just being alert and aware that you may have to administer CPR at any moment, as opposed to being completely unaware and being like, oh, wait, is that guy dead? And then, like, taking several minutes to identify the need for CPR, which is precious heartbeats lost. I think that's what that's referring to. So the answer is, in fact, D. We don't want to move the patient as quickly as possible to the ambulance for transfer. All right, finally, hypoglycemia occurs when a patient consumes too many high-fat foods, has enough insulin but not enough blood glucose, suffers severe dehydration, or has too much blood glucose and not enough insulin. All right, it looks like a lot of us have the pathophysiology of this down pat. So hypoglycemia, hypo means low. Glycemia refers to sugar. Glyce is sugar and emia is blood. So low sugar in the blood. So already, just from the word, we know that there is not enough blood glucose. And so if we knew nothing about insulin, just from the word hypoglycemia, we see not enough blood glucose, and we know that it is B. All right, so we have 15 minutes, and I'm going to launch right into this. And it's 73 slides, but we're not going to go through 73 slides. All right, so again, I'm going to beat this dead horse into glue. This is the systematic approach for assessing a patient. Do this every time. So poisoning can be classified according to the way the poison enters the body. Ingestion occurs when it enters through the mouth and is absorbed by the digestive system. Inhalation is obviously through the mouth and nose and absorbed by the respiratory tract. Injection occurs when a small opening in the skin and it spreads into the circulatory system through the tissues or directly into the circulatory system. And absorption occurs when it contacts the skin and is absorbed through the skin into the circulatory system. Even though poisons can be introduced into the body by different routes, a lot of them have the same effects on the body. So you may find a lot of overlap here. So again, your general assessment and treatment here, follow the patient assessment sequence. Obtain a thorough history from the patient or from bystanders if you can't get it from the patient. And be alert for clues that indicate poisoning. So traces of the substance on the person's face and mouth, traces of the substance on the skin, needle pricks, sting marks, track marks, respiratory distress. A lot of the emergency care for poisoning depends on the patient's signs and symptoms. So talking about ingested poisons, this constitutes more than 80% of all cases. A lot of these people are kids. Chemical burns, odors, stains are often found around the patient's mouth. And so with this, we're going to see nausea, vomiting, and abdominal pain because that's where we put the poison, into the digestive tract. We also, if it gets far enough, we also may see diarrhea. If it gets absorbed into the system, we'll see changes in their breathing, loss of consciousness, and potentially seizures. So what are we going to do for them? Well, we have to figure out what they took, and then it's best to call the National Poison Control Center. And so you're going to see this number a bunch. It's 1-800-222-1222. And you'll see stickers next to phones. I have one of the stickers later on in the slide deck. That's what it is. So if you're unable to contact Poison Control Center, bring them to the emergency room. One of the things that we can do if we're instructed by Med Control or the Poison Control Center is administer active charcoal or activated charcoal. Activated charcoal is exactly what it sounds like. It is finely ground black powder that you generally have to mix with water. It's supposed to work by binding the poison and preventing it from being absorbed. It only works with certain types of chemicals. I actually just recorded a podcast about this. If you're interested in toxicology, it's a pretty interesting discussion with a toxicologist, and we talk about activated charcoal and how it works. Pretty interesting stuff. And so here's a bottle of it. The instructions are on the outside. Honestly, I have not used this in 16 years of being in EMS. I've never once pulled this out, not even as a prank. So it looks like mud. The patient has to be capable of swallowing, which means they have to be conscious. Do not do anything to induce vomiting. Because someone swallowed something doesn't mean that you're going to have them vomit that up, because whatever injury that it caused on the way down, it will double that injury on the way back up. So this is especially true for acidic or very caustic substances. For inhaled poisons, a lot of the inhaled poisons that we come in contact with are carbon monoxide and cyanide, but there are other toxic gases like chlorine gas or ammonium that will cause irritation to the respiratory tract. In any case, what we generally see with inhaled poisons is some sort of respiratory distress and then signs and symptoms of hypoxia. So dizziness, headache, confusion, all sorts of stuff. And so carbon monoxide specifically is pretty insidious because it takes the place of oxygen in the blood. And so the antidote for this is oxygen, right? So all of these signs and symptoms, very familiar. The solution to pollution is dilution. The solution to carbon monoxide poisoning is to just give them as much oxygen as possible and kick all those little CO molecules off the blood. We may also come in contact with other inhaled irritants. So ammonia is pretty common, not just around the cat box, but also in agricultural settings. And we do have quite a bit of agriculture here in New Hampshire. And so we can usually tell by the smell that there's ammonia, but at super high concentrations, the smell actually goes away and it becomes very, very difficult on the respiratory tract. The same with chlorine. This is a very, very common disinfectant, and it's used still in water supplies and things like that to treat water and keep it sanitary for use. But in high concentrations, it can absolutely have a devastating impact on the respiratory system. And in a lot of cases, and you'll learn this a little bit in the AWR 160, they'll talk a little bit about hazmat, but there are ways to identify a hazmat scene. And so again, the treatment for inhaled poisons, you want to remove them from the source, obviously. Don't expose yourself and remove them from the source as soon as possible. If they're not breathing, then you're going to breathe for them. If they are breathing, then we're going to give them a ton of oxygen. Again, the solution to pollution is dilution. And arrange for prompt transport to the most appropriate medical facility. All right, so I am going to skip ahead where this wants to talk about treatment for bites and stings. It wants to talk about absorbed poisons, which are relatively uncommon. Wants to talk about chemical warfare, which is fun and exciting, but we're going to skip over that. And we'll go straight to substance abuse. So the most commonly abused substance in the United States is alcohol. Alcohol is a respiratory depressant. And so in really high doses, we see that the symptoms include depressed respiratory function. So they start breathing slowly. There's also a host of other long-term implications and a host of behavioral implications that go along with high alcohol consumption. And then, of course, if you are physically addicted to alcohol, the withdrawal from that can actually kill you. So very rarely can you actually die from withdrawals of anything. Alcohol is one of the things that will kill you. And severe withdrawal is known as delirium tremens, right? And this is something that they have to be admitted to a hospital for and monitored over a period of time. Other ingested drugs, there's a lot of them out there. There's no point in covering all of them. There's a lot of information and misinformation on drugs. And so I encourage you to go out and seek continuing education on this, especially here in New Hampshire, where we see a mix of things like amphetamines, opioids, and other types of things. Before we end the class, I want to talk specifically about the opioid crisis that we're experiencing. So opioids are a class of drugs. They contain a bunch of different substances and with all sorts of names, both trade names, street names, and drug names. So hydrocodone, also known as Vicodin, oxycodone, marketed as OxyContin, morphine, which is a classical derivative of a plant, and codeine, which is a little bit more refined. We also have things like fentanyl, which is a synthetic opioid that's used extensively in medicine. It's one of our primary pain relievers for surgery and EMS and things like that, but it is very powerful, and if dosed incorrectly, it can lead to a rapid, profound overdose. And so what do we see when people overdose on opiates? Well, again, it is a respiratory depressant, and so it slows down their rate of breathing so that their breathing is slow and shallow. And we know from other things that we've learned that slow, shallow breathing is inadequate. So what do we do for someone who has slow, shallow breathing? What is the first thing we do for this person?
Fix their airway.
Diagram.
So the very first thing that we do is open their airway.
That's
and the
not
very
enough.
next thing we do is a bag valve mask, right? Would you agree with that?
Yes.
Okay.
Yes.
And then So once we have the airway open, once we are administering oxygen and giving artificial ventilations, then and only then would we consider giving a drug like Narcan, right? Because Narcan, all Narcan does is reverse the binding of the opioid inside the body, right? So it will reverse, whatever opioid magic it does, whatever pharmacology it does inside the body, right? But they're still not breathing, and they still don't have oxygen, right? And so if we give Narcan and we haven't opened the airway and we haven't started breathing for them, they're not going to get better. And so what we see is a lot of people will rush to give Narcan and they won't do this other stuff, and they're surprised when the patient wakes up in a profoundly hypoxic state, confused and angry and upset, right? Well, the reason is you did it out of order, right? It goes A, B, C, decision to transport or update dispatch, and then your secondary assessment. And that's when we're going to administer a treatment like a reversal agent, right? And so Narcan is something that we do after ABCs. Narcan does not fix any problems. It merely reverses the cause of a problem. We fix the problems by opening the airway and providing artificial ventilation. Really, really important. All right, so at this point, the presentation goes on to talk about a bunch of other sort of abused inhalants, huffing and a bunch of drugs that we don't really see a whole lot on the street. But I am going to skip to this, which is really important. If you come across a toxicological emergency and you don't know what it is, you don't know how to treat them, right? You've done your ABCs and you don't know where to go from here, you can always call for help. And the number is 1-800-222-1222. And you should not be ashamed to call this number, because guess what an emergency physician in the emergency room is going to do when this patient gets in there? They're going to call the poison control hotline, and they're going to ask the toxicologists who specialize in this. And all they do every day is answer phone calls from people who have ingested toxic substances. So these are the experts. These are the people you want to call. These are the people that the physicians are calling, the paramedics are calling. So go ahead, and it never hurts to get another assessment. All right, so to summarize everything here, EMRs need to be familiar with signs, symptoms, and treatment of patients who are experiencing accidental or intentional poisoning. The four primary routes are ingestion, inhalation, injection, and absorption. Ingested poisons are taken by mouth. There may be chemical burns, odors, or stains. Inhaled poisons are breathed in. Some toxic substances, such as carbon monoxide, are very poisonous but not irritating. Other toxic gases, such as chlorine, are very irritating and will cause coughing and severe respiratory distress. The two major causes of poisoning by injection are animal bites and stings, and then toxic injections. Poisoning by absorption occurs when poison substance enters through the skin. This is generally not a very common method of poisoning, since the skin is really good at what it does, which is keep stuff out. So, for example, you're not going to overdose on fentanyl if you touch some white powder. It just doesn't work like that. Chemically impossible. Many nerve agents are the same types of chemicals used in insecticides for agriculture. Fascinating stuff. It's important to pay special attention to scene safety and not enter a hazardous environment without the proper training. And then we talked about Narcan, which is a rapid reversal agent for the effects of opioid drugs on the central nervous system, and it should only be administered once you've done ABCs. All right, so that's all I have for you tonight. Took you right up to 10 o'clock. Does anyone have any questions before I cut you free?
Yeah, did you say, I remember you saying last week there was a time that you were going to go over like the upcoming test and some of that stuff. Was that going to be next Friday?
That would probably be next Friday.
Okay.
Unless you're talking about our final exam.
Yes.
Okay.
Yeah.
Well, why don't I do it next Friday, so I'm not keeping people like super late past 10, because we all have to be up early in the morning. And if you have any specific questions or anxieties or things that I need to answer for you so you can rest at night, I will be happy to do that over email. Otherwise, next Friday, the 18th, is office hours. So we don't have class. I'm not going to be presenting anything. I'm going to be logging on here at 6 p.m. and I'm just going to sit here until 10 p.m. And you guys can jump on whenever you want, ask questions, and that'll be that. So I'm happy to go over whatever you need then.
Thanks, Mark.
Absolutely. Have a good night.
Yes.
Sophie asked, what time does class start and finish tomorrow? The same time as it did last week. We're going to start at 9, and we're going to push through until about 5 o'clock at night with an hour break for lunch. Catherine says B. Oh, she's changing her mind. No, you got it right the first time. Go with your gut. You got to go with your gut.